the health informatics and artificial intelligence, as well as in psychiatry. So most of my work is in the intersections of bringing informatics and AI into like studying youth mental health. And I was actually also trained as in the social work school, and I was able to being connected with Julian, and Julian later on connect me with Lonnie. And starting from then, I started to know that actually a lot of my work that I've been dreaming about is actually possible, and it could be important. And then we managed to do it throughout a journey of starting from curiosity and then starting from bringing different disciplinaries to make it happen. So my talk today, I'm going to discuss about using machine learning to investigate policy relevant social determinants of health to use mental health, and my field also focusing on suicide prevention. So I'm gonna touch base on suicide rates in the United States. So some of the disclosures. In general, I usually tell people that I'm being in this Venn diagram that I use a lot of social science and data science to reduce health disparities and then improve mental health. So a lot of my work is centering on addressing social determinants of health, how to measuring that, and then how do we approach them to inform like policies. And this work has been led to really inspired by Lonnie when we are talking about how do we measure and do the analysis. So I have been done two of the work, and both of them, Lonnie, are the co-authors, and I wanted to share with you today. One of them is at the county levels, and we are extracting using machine learning approach to link 284 variables across all the 3,018 counties, and then associated with suicide rates across 10 years. So it's a large amount of computational analysis to do. And I also get to know about GWAS study, and then one of the plots I will show you is about, like I remember I was talking to Lonnie that, can I bring this kind of plot to show this importance of different variables? And he said yes. So I'm very encouraged by that. Another thing that, another area that I have been also extracting is about subphenotyping, meaning that that's more clinical informatics word, but in terms of policy part is that from my research, I'm focusing a lot on like addressing disparities, and then that is really to show the differences that some subgroups could expose to different social determinants of health, and then link them to their longitudinal part of mental health. So why that is important? I started to address suicide like prevention since I was a master's student, and then later on moved to New York for over like 10 years right now. And we know that suicide is the second leading cause of death in the United States across 10 to 34 years old. And a lot of my research in the beginning since the beginning, started to like really dissect that suicide rate is not, we cannot really move forward with a one-size-fits-all approach, because that we have been seeing a lot of disparities. For example, racial disparities, like Black youth are the only group that have increasing suicide attempts like versus other racial groups. And then within all of them, we have also showing like among Asian Americans that sexual minority populations are particularly a very like vulnerable group that have been showing higher rates of attempting suicide without even sharing about their suicidal ideations. Some of my early work also addressing like there are geographic differences, temporalities that really need to address. The growing crisis also focusing on like non-metropolitan areas that has been increasing over 46 of the rise in suicide rates in the past 20 years. But the challenges has been really to understand how the complex social environment have been driving these disparities, because we are not just focusing on the demographic disparities, right? We really need to know what is the environment that people are living in that might drive this suicide crisis, especially these geographic disparities and then later on showing in the subgroups. And one of the important parts that has been brought into the stage is social determinants of health. And I think it is not a term that is unfamiliar with this group. It is defined as the conditions where people really live and born, learn and work and worship. So a lot of studies has been suggesting that this unfavorable social and environmental context, like poverty, discriminations, poor housing, limited care, and for immigrants, there are also on access about language issues. These barriers has been drive the disparities and elevated the suicide rates. So of course, so that really highlights the importance of doing this work, that to address these upstream factors is critical to addressing and closing these gaps in this children's mental health. However, through a lot of literature reviews, we have been seeing that the traditional ways of defining and studying social determinants of health has been quite limited. And first of all, many of them have been focusing on fewer domains or one part of the domain. For example, economic vulnerability, social vulnerabilities, like area deprivations, or one of the papers, some papers focusing on green spaces related to disparities. And then the second part is that there has been studies focusing also on the contextual levels of the factors, but not really narrowing down to how this one context can be clustered together across different domains. And then also there has been a risk of ecological fallacies when just association with a county level poverty rates to generalizing to a county level suicide rates, or just simply define here is the hotspots, but not really inform about what do we need to do? And policymakers then lack of solutions to say, should I address to poverty or should I address to the health access? So a lot of domains haven't been really covered in one area. That is actually social determinants of health is a multidimensional concept. And we should not just cherry picking in terms of what we want to do, or just using a smaller set of the social determinants of health variables. So then that really drive to my curiosity is that can we use for example, the machine learning algorithms to compute unbiased computational social determinants of health patterns to really conceptually, not just conceptually, but really empirically, statistically identify the certain high-dimensional social determinants of health factors to see how they are really associated with these areas, or later on answering, asking questions for different individuals really living in those areas. So the first studies that we published in Nature Mental Health is on the county level analysis. So as we know that the limited areas that we wanted to focus in on is to really have a full spectrum of the social determinants of health across different regions. And then another thing that we also thinking about is that when we are creating this new measurement, can we really bridge the gap about simplifying everything to just one index? Because we all know that, for example, area deprivation index or 17 variables, social vulnerability index have 16 variables. Yes, they do cover different domains, but they just simplify everything into a single score, which may not be exactly informative in terms of what area exactly are these counties in these groups are lacking. So then we managed to have more innovations in terms of like beyond a simple score. How can we build a rich indicators that can characterize all of the factors? And then what we did is to use this unsupervised machine learning to transform like over 284 variables. And then why this 284 variable is because we selected 10 years from 2009 to 2019 years of the social determinants of variables collected at multiple administrative centers. And then we make sure that they are consistently measured because there are new measurements that coming in, but unless that we can be able to collect the same variables, we will not be able to replicate it later on. So the goal is to really identify like the variables that are consistent, accurate, and will also continuously getting measured. So I actually went through all these variables one by one and making sure that they are meaningfully collected with the social determinants of health related to suicide as well. So we aggregated and collected and link all the social determinants of health variables to all the counties. And why it is 318 is because some of the counties also changed their names, merged to the other counties, but we make sure that it's consistent with what we define as the CDC context. And we defined, we measure all of them across the 6 domains: social factors like demographics, economic factors, education, physical infrastructure, healthcare context, and one of the things is environment, because I focusing a lot on climate change a lot in my research, and I think that is really separate from physical infrastructures, and we coverage it from over a decade. And then the method that we use is hierarchical algorithmic clustering algorithms. And when we use these algorithms and then toward the word linkages to identify each of these clusters. Basically, what it does is that we estimate from 1 cluster up to 15 clusters to see how these 3,000 counties can be clustered to certain groups, that among each of these clusters that they are sharing similar levels of exposing to different domains of social determinants of health. And then within different domains, we also have subdomains. And we also do a data pre-processing so that each of these domains variables are consistent, meaning that for poverty, that means that it's positively associated with suicide rates, like more poor than in the literature saying more higher suicide rates. But for example, psychiatric beds, better and more beds could be negatively associated with suicide rates. So we also reverse coded those kind of variables so that when we are interpreting today's clusterings that we identified, they can be more interpretable. So we went through all of these clusters, and then using this model fit index that we identified 3 clusters across all the counties, and I named all the 3 clusters based on their characteristics of social determinants of health. And in order to make them more memorable, I make them the first cluster, the red part, is called the remote. Those are the rural area having more elderly populations. They are marginalized environments and also older housings. They use traditional energy systems and have a lot of empty houses. So those are remote areas in the counties. And the second one is called cope. You can understand that they have complex family dynamics, meaning that they have either single parents or divorced families. And then they have high consumptions of health services. They have like poverty rates is high. I mean, absolute poverty is very high. And then there has been extreme heat exposed to these counties. And then those are the blue part of this like diagrams here. So the final one is called diverse. Within these counties, like within these clusters, counties have like diverse, dense populations. They have a lot of immigrants. Like they're facing a lot of like environmental challenges. They are also having economic problems, but it's not like absolute poverty, but it's like relative poverty. So, for example, the Gini index later on you'll see is very high, and then they have a lot of like racial diversities, and they have saturated healthcare, meaning that they do have a lot of beds, but people cannot get access to them. So it's quite saturated health systems. And finally, these clusters have a lot of like expensive housing. And then in terms of the prevalences, we see the majority of these counties are falling into these remote groups. And then the second large one is like over 1/3 in these COPE counties clusters. And the last one is the diverse counties. So believe it or not, we are in the diverse counties. Like the diverse counties are California and New York. But within California, I remember have a long discussion with Lonnie that actually within California, there are also heterogeneities across these three clusters, because in California, there are also diversities as well. And then this is one of the plots that I adapted from studying genetics and genomics. But within each of them, you can see that the higher like of this like rates, the y-axis, meaning that these variables contribute the most to why these counties are in each of these clusters. For example, that the remote clusters, you can see a lot of like housing issues, like the language issues, education issues, the lack of long-term like hospital bed. And then the second one, for the COPE one, you can see a lot of uninsured people are in these areas. And finally, this like diverse group, very high rates, rents, like rentals here as well. And then the economic problems like features in like this annual PM like rate 2 is very high as well. So even within each of these clusters, then we can see a particular part, like have we given like this amount of like investment, which is the exact precise part that we wanted to address. And of course, after we identified this, we wanted to visualizing them into geographic levels. And as I mentioned that the remote levels, remote clusters are predominantly in like the north and central part of the US, Montana, Wyoming. I was actually planning to see if I want to go to Wyoming, but I really wanted to know that, oh, actually in these parts that there are really a lot of like places that lacking of access. The second is primarily the southern part of the US, like the Texas, Alabama, Georgia, and then clusters in the third groups, as I mentioned, they are like the coastal, like west and east, California and New Jersey, New York and Massachusetts. And within each of this, in the paper we show like within each of them, they also have within state heterogeneities. And then there are also some of the temperature changes, but not very large. And then the driving part of these temperature changes is that there has been increasing use of healthcare, and then particularly within these diverse groups. And then there are also worsening environmental challenges in these diverse groups. So people are within these diverse clusters are really facing a lot of like usages, but also lack of but also like unmet needs of their healthcare. And why that is important? because like when we are associating them across like mortality rates of suicide rates, we really see that, for example, like the remote clusters, they are the leading causes of like higher rates of total numbers of suicide rates and also men suicide rates. And then clusters within this COPE group having more females like suicide rates across over the years and increasing. And more importantly, I think for me, when studying like youth suicides, people are living in this diverse group that they are county levels and high rent, populational densing groups, also having facing more and more like suicide rates. And that has been consistent after we addressed for other kind of variables. And then we see that when we are comparing each of the clusters to each other, we really show that this association between the social terms of health clusters and suicide rates are very consistent over time. So what's the take-home messages, like particularly for addressing these disparities? Because we see that within these like cluster groups, like for examples, like a diverse cluster have higher suicide rates, like Hispanics, as well as like Black individuals compared to like even people in these remote groups. So addressing, if we wanted to address racial disparities in suicide rates, like suicide deaths, then we are really needed to focus on those groups. And particularly, as I mentioned, that for those in the youth, in the diverse areas, they are also showing significant increasing of like suicide rates as well. So policy implications, why is this policy relevant? We're really using this approach to show that it is not a single solution that can solve all, and then social determinants of health is just not one dimension. And then it's multi-dimensional in the case that, for example, for counties in the remote cluster, we really need to reduce like social isolation, increase their access to healthcare, as well as housing and building transportation infrastructure so they can access to the care. For people who are living in these COPE clusters, these counties really need to address economic stress, like addressing absolute poverties, addressing substance and alcohol and overdose issues. And finally, for people living in counties in the diverse clusters, we really need to improve more culturally adaptive, like mental health programs. They are living in urban areas, but we need to also thinking about how do we embrace like urban like healthcare so that everybody can access to quality of care if they really need it. It's not just because of quantity is there, but we really need to make sure that people who are insured and also having access to it. And I wanted to go through the second like methods that we also adapted to studying individual levels of social determinants of health, because previously I show you those are at the county levels only. But the next question I wanted to answer is that, can we identify these social determinants of health clusters and link them to real individuals? And then using their like real exposures to different social determinants of health to cluster the individuals versus like the geographic areas. Because then we know that if we survey the individuals and asking their mental health, we know exactly that those are the groups living in the similar levels of the social determinants of health, and then the outcomes is at the individual levels that precisely addressing their needs. And then the answer is yes. So I'm a painter when I was like since I was 3 years old. So I painted this to really show that for kids, for children, this is the color wheel that we need for their mental health. And I actually added 2 areas. One is about bias. It is using a Harvard like research development group, and then they surveyed at the state level the implicit bias to sexisms, racisms, sexual orientations, and immigrants across the 4 indicators. So the higher that these variables, the higher bias or or stigma the people living in this area feel. And for kids, I also identified areas that relate to early child care centers that are very important for them, school-based mental health. Susan is sitting here, so I'm not going to speak too much. And then later on, also crime and drugs are very important for them to living in a safe place. And we use a very diligent group of analysis to go through all the variables to do the data cleaning and then also to do the data transformation to making sure that later on when you see the variables that each of them, the higher the social health variables, the poorer that the mental health, like the worse that it will be associated with. So I wanted to jump into this graph that I showed because after we do the similar levels of machine learning dimensional reductions approach, we find that kids among our population of over 11,000 of the children can be reduced to 4 groups. One group is fortunately living in more affluent population. So all of these poor and worse social terms health variables are under 25%. So they're relatively safe. The second one is that they are relatively good in other part, but the yellow part, which is implicit bias, sexual orientations, sexisms are very high, as well as like facing environmental challenges. The third part I will point out and highlight it is that these are the traditionally like poor socioeconomically deprived areas that we can see that education, especially like this green and also teal colors, that we can see that they have high income disparities, housing values very high, high rent, high poverty rates. So everything here is very high, as well as like social context, like single parents are very high. Also an index called Opportunity Atlas Index, also very high in terms of like the social mobility in those areas that they live are very low. Finally, the fourth group is that they are doing relatively also bad in terms of this socioeconomic status. But look at that, the final part of the green area, which is the crime and drugs, are super high. So they have high crime and high drug sales. And why that is important? We have a lot of like outcomes, but one of the key messages from this is that, first of all, these different groups are differently associated with the different mental health variables. We have internalizing problems and externalizing problems, problem behaviors, the mental health scores, and suicidal ideation and behaviors. But in the nutshell, the third clusters, which is children who are living in the socially like deprived areas, are really the group that consistently showing, like you can see the orange dots here, higher rates of like mental health problems, as well as longitudinally later on when we do the second study, when we see that they have increasing trajectories of reporting like suicidal behaviors, so which is more severe in terms of like their mental health. So I'm happy to close this this talk, and I like the tree in terms of like the graph, because I think yesterday I was also very inspired by like different generations sharing the talk, and I mentioned about like we have been having email communications throughout the last week that Lonnie passed away. And yesterday I said that one of the email that he sent to me is like, I will talk, I'll get back to you. And then at least also share that on that we have been getting back and forth in terms of email. It was because the next stage of my research, like after these 2 studies, is really to show, can we use the same method to study health policies that are addressing it? And I wasn't sure because I really cannot find a study on Google Scholar. But Lonnie has been giving me a lot of like encouragement. And then as you can see that his words is always very like encouraging. And then also I think he also endorsed you in terms of like why that matters. And I hope that I can also carry some of his wisdoms and also curiosity, kindness, and also the commitment to really push the boundaries to understanding mental health disparities and to help also to help next generations as well. Thank you.
We have some time for some questions, if anyone has any that they would like to start off with.
Hi, thanks, Yunyu. Really great talk and just really thoughtful and, I think really a testament to your work and your collaboration with my dad. And I love the figures.
Thanks.
My question
Yeah.
had to do with your hierarchical agglomerative clustering method.
Yeah.
Were there features of that learner that motivated you to choose it, or how did you arrive there as your learner?
Yes, so there are a lot of like machine learning algorithms like k-means or PCA to reduce like data dimensions. But this is an approach that we choose because it's more flexible. And then also like the variables that we include are sometimes like categorical, sometimes like they are also continuous. So we're using these word linkages as well. It can really be more efficient in terms of the computational powers, and also it can also demonstrate that it also can link to different measurements of like a data like model fit, and then we can really use this method to reduce the data. Basically, it's because like the social determinants of health variables that we choose and not just like one dimensions, but it's really different kind of like complexities of the data.
Thank you for a fascinating presentation. I had a question as in terms of guiding the selection of the variables. Imagine you have two that are very, very highly correlated, and at some level, the one that the machine chooses is somewhat non-informative. It's making a choice. Can you guide it to choose the one that is easier to respond to in terms of policy? So income through earned income tax credits or child tax credits is something we can change very quickly as a matter of policy, and housing is much more difficult. Is there a way to guide this process towards those policies that are easier to implement quickly?
Yeah, I think that's a very interesting question. I think it breaks down to two parts. One is the correlation part, and then the other is the selection part. For the correlations, like when we are doing the clusterings, it doesn't really matter if like, for example, housing rent is highly correlated with the number of houses or the geographic like areas like the like population densities, because when the counties are falling into one clusters that the machine choose, they are within the same clusters, which means that you can be, for example, you can be an introvert, and then you can also be in the dimensions that you don't want to talk to people. You need your isolated time. So it's the beauty of I think using this approach is that it doesn't really matter in terms of the correlation itself, but it's really to characterize like a whole dimension, a whole holistic view of like these counties. So that part, I think we didn't really care because then we just need more information to tell the same thing or to characterize the same group. And then for the second part, I think it's more related to the next step of what we want to do, because like we could achieve the same goal of like reducing poverty by giving people money, tax credit, or like helping people to find jobs, increasing the employment rates. But I think that is a empirical question we haven't tested yet. That is the part that I wanted to do in the next step, because I think it can really improve the efficiency of making decisions.
All right, and this will be our final question before we transition to the next speaker.
Thank you. Thank you very much for the presentation. Very inspiring. I'm thinking about this new strain of research that is looking to do some kind of like clusters to also identify where policies will have the higher impact, in terms of like saying, okay, here we'll have like these counties, you already identify like these groups. Then they include like variables in terms of like the impact evaluation literature that adds like an extra, like set of vectors that you include to the cluster, and you see where they have like the biggest impact. Have you thought about something like that, like including like policy variables like directly into your model?
Yes, I think that's actually related to the previous questions, and I think there is a chicken and egg questions that I think is to be discussing, because first of all, there might be some problems or some needs, right, in the counties, so that drives the policy choices historically to address this. But then, because of the policy choices to addressing the social determinants of health, there might be improvement or may not be improvement. So it's kind of like hard to, first of all, disentangle. Like, should we say that this is a problem first or policy first, or the policy really effectively addressing the social determinants of health? So that is a first line of design, I think, that needs to do in a future study, that you see like, maybe to do a cluster of these policies, and then to address like what happened historically, and involving like policy analysis to evaluate like the improvement, the changes of the social determinants of health. The second part is that whether to cluster policy and social determinants of health together. I think that is also like in terms of the research question, right? Because for this research, we wanted to really identify the context first, and then to identify how these different contexts associated with the suicide rates. But if you are really interested in what happened related to everything in this area descriptively, and then you can use the same method to do that. And then you can perhaps knowing that some areas are persistently having words, always be in the COPE clusters, no matter what kind of like policies are doing there. So that means that we need to change our mind. So I think that's very interesting question, but different from this, and definitely worth to pursue.
Thank you.
Thank you so much again, Dr. Xiao.
Thank you, Professor Zhao, for your wonderful presentation. I also want to thank those who are joining us virtually. Hi, participants. And then I want to turn it now to Dr. Genevieve Graaf, one of our own very own social welfare alum. Take it away.
Why, thank you. Do I need to turn this? All right. Welcome. Thanks so much for having me today. Thank you so much for inviting me. Dr. Stone and Dora, you've done such a great job in coordinating all of this. My name is Genevieve Graaf, and I'm an associate professor as of September 1 in the School of Social Work. Thank you. Thank you. Felt it was important to say that because I don't know that I would have gotten here had Lonnie Snowden not been such a wonderful mentor. I'm at the School of Social Work at the University of Texas at Arlington. And this work was supported in part by a grant from the National Institute of Mental Health. So I'm just going to do a tiny bit about my background and my work with Lonnie. Is it too loud? No. I'm a louder talker. Okay. I was a graduate from the School of Social Welfare here in 2018, and my dissertation chairs were Lonnie Snowden and Susan Stone. And my work with Lonnie started before my dissertation, when I went to him and I said, I have this Medicaid policy that I'm interested in, and only some states offer it, and it's for kids with mental health needs. And why has nobody studied this before? Is there something I should know? And he just was like, no, states are just hard to study. And I don't think that should stop you. So from these conversations, we kind of developed a pattern that went on for about 10 years where I would write a paper about what I wanted to write about that was related to states and financing and children's mental health. And he would invite me to support him on the papers that he was leading around the roles of policy and financing and Medicaid in mental health disparities. And so this continued beyond my graduation to my years at UT Arlington. We basically continued the same pattern. You'll see a lot of papers that it's Genevieve and Lonnie, Lonnie and Genevieve, Genevieve and Lonnie, Lonnie and Genevieve. And you'll also see a pattern that there's, a state policies around youth mental health are the things that I led, and the things that Lonnie invited me to be part of were around the role of Medicaid and other policies in relation to racial disparities. So the work I'm presenting today is kind of a culmination of that relationship that I had with Lonnie, and it's not nearly as fancy as anything anyone else is going to present, but it's really what I consider to be pretty foundational to the work that Lonnie and I were pursuing, which is that there is variation across states in who can access mental health care, and that geographic variation in some places is larger across state lines than it is across racial groups, income groups, or insurance groups. And this is foundational because it's the thing that motivates why we should study state policy. So I'm going to present first a study that just looks across state lines and tells you it's a descriptive study. It uses national data that demonstrates what the differences are across state lines in access to mental health care for children, and compares those differences to gaps in across racial or ethnic lines or groups and income groups, as well as insurance groups. And then I'm going to present a second study that was inspired by the first study and is the very first study that I led that had to do with racial disparities in mental health. So it was kind of my growing up moment where I got to become the researcher that, I hope Lonnie is proud of. And I dug deeper into this question about differences across state lines. And I said, I wonder what the differences are in disparities across state lines. So do the size and direction of racial disparities or ethnic disparities in access to mental health care for children look different in different states? So what motivates this study? This is one a lot of us already know, approximately 16 to 20% of children in the United States have a mental health problem, but only about half of these kids access mental health services. And there's a wide range of factors that influence that. I didn't feel like I should put them all on the slide, but one of them has been identified as geographic. There are geographic drivers of access to mental health care. So to motivate most of my work up until this point, I have always pointed out that there's a study from 2003 that draws on 1998 data from 16 states that is, up until recently, the only study that demonstrated that geography and that state-based differences were something to note. This was published in Pediatrics. And after about, several years of using this study and citing it and having reviewers say, can you update your citation because we need more up-to-date research on this, there was no updated study. So that's actually why I did this study, was because there wasn't any updated study. There actually was, that has come out since I started this study. So I was like, darn it, but mine is still a little different. But the goal was to update this study that was from 2003 that demonstrated that at least in 16 states, the differences across state lines were at times greater than they were across racial, ethnic, income, or insurance groups. So I said, is that still true today? And hence I did this study, but also because reviewers kept telling me to get an updated citation. So my goal was to estimate the size of state level disparities and unmet need for mental health care and difficulties in accessing care among children and youth across the United States, and to compare this variation across states with variation across other demographic groups. This is the part that I can skip a little bit because I know we're going to run short on time, but essentially this is pooled data, pooling 4 years of the National Survey of Children's Health. I identified children as having a mental health problem using methods that are set out in Bethel and colleagues' 2002 article. And I required and also tagged children that had a mental health problem according to this algorithm and needed mental health care. So my final sample was about 12,000, 13,000 kids. And I included all 50 states and the District of Columbia. The measures included caregiver reported unmet need for mental health care that was defined in a really specific way that you can look at the paper to find out. The paper has been published, and caregiver reported difficulty in accessing mental health care. So essentially, caregivers were asked, did your child use mental health services in the last 12 months? And if they said yes, that was not unmet need, that was met need. And if they said no, but my child needed mental health care, that was counted as unmet need. And then there was an option for caregivers to say my child didn't need mental health care. But if they had said, yes, I did access mental health care, or yeah, no, but my child needed mental health care, they were asked a follow-up question that said, how difficult was it for you to receive care? And they got to rate it on a four levels, I think. Not difficult at all, somewhat difficult, very difficult, or I did not receive care at all. And so it was coded binarily that if there was any difficulty at all, it was rated as having difficulty in receiving care. And my covariates are listed here. So to estimate the size of state level disparities, I use just logistic regression with state and year fixed effects, controlling for the covariates you saw. And I just use post-marginal estimation to generate predicted probabilities for each outcome for each of the 50 states and Washington, D.C. And then my second objective was to compare how much the variation, how big the variation or how wide the variation was across state lines with the amount of variation that we saw across these other subgroups. So I did the same thing with my logistic regressions, and I had three categories of race, I think. I guess we'll find out when I look at the findings. And I just did the exact same thing for each of the 4 subgroups and compared the ranges and standard deviations across these subpopulations with the ranges and standard deviations for states. So this is just the pretty picture results to me because there's such great nuance and variation across all of these states. It's hard to really tell, but certainly some states pop up as quite dark orange, which is higher rates of unmet need and higher rates of difficulty accessing care. Mostly I just put that in because it's pretty. This is the one that I think is more useful, that if you're interested in knowing where your state lands, this can tell you the little bars on either side or the 95th or the confidence intervals. And this tells you, this links the rates of unmet need for mental health care to the United States average. So it tells you where a state falls in relation to what the rate is for the United States. And then the purple and green lines are the 95th percentile. And your blue dots are your state estimates. So as you can see, the extreme far right and the extreme far left, although more in the far left, there's more states that have lower rates of unmet mental health need than the national rate, and far fewer that have statistically significantly higher rates. And in fact, it's only Utah. Interesting. Utah also has the largest child population, just in case anyone wanted to know. Texas is number 2. So unmet mental health need, difficulty accessing mental health care. So you'll see that there are, again, more states clustered on the left that have lower rates of difficulty accessing mental health care than the national average, and a few states on the far end that have significantly higher rates of difficulty accessing mental health care than the national average. So I don't know, California is usually somewhere in the middle, not statistically higher or lower than either of these measures. And then I guess this is where I already described it. I forgot another slide for it. But these are the four groups, the 4 racial and ethnic groups, the 4 family income groups, and the 4 insurance groups that we generated predicted probabilities for as well, and compared the variation across those groups with the variation across states. And this is what it looks like. So you can see this is just a box and whisker plot. You can see that the upper bound and lower bound are significantly wider across states than it is across any of the other groupings. But the standard deviation is fairly large, which implies that really some of this variation is due to a few states having pretty extreme values. And then for difficulty accessing mental health care, it's even more extreme, the variation across states compared to the variation across the other subgroups. I might just, yeah. So the conclusions from this study was that there is evidence of significant geographic inequities in access to mental health care across states. And comparing this to the findings from the 2003 study that I was trying to update, data from 1998 showed that Texas and California had some of the highest rates of unmet mental health need in a sample of 16 states. In 2007, Texas had the highest rates of unmet mental health need, and California was among the highest as well. So these states do look a little better in this study, but are still not great. The comparison suggests that while policies have continued to evolve and change over the last 20 years, there are likely deeply entrenched policies, processes, or conditions in some states that change minimally over time. And this is also consistent with evidence that significant federal and state policy changes, including mental health parity legislation, the Affordable Care Act's essential benefits mandate, and other changes at the state levels have done little to increase access to mental health care for children, because this is about the same as what we saw in 1998. Probabilities of unmet need among children and youth varied more widely across states than across other subgroups. And I think this is important too, because this means that as we move into a more and more devolved federal state, where more and more control is being given to the states, there's a lot of history to look at and understand what drives access in mental health services. And as more and more control is moved to states to make these decisions, I think this is an important area to continue to examine. These studies do show that there are continuing inequities in mental health access for children if you looked at the subgroup analysis. I am concerned that the state of residence that a child lives in may compound this risk. If you are already less likely to access mental health care because of your race or your income group, and you live in a state that has significantly lower rates, significantly higher rates of unmet need, what does that look like for more disadvantaged children? Let's see, what else were some of my thoughts? Oh, yeah. Well, basically, well, this is what Lonnie would say. That this is what points to the need for systemic or structural perspectives when you're examining state differences. And as I said, this can inform future policy as we move forward in a more devolved state. Maybe that will change, but it looks like we're moving more and more to state control. And states have so much autonomy that we need to understand what they're doing. And because Black children especially, but also Hispanic children are overrepresented in unmet need across the United States, and in my next study will show in certain states especially, it's important to examine what this looks like and the disparities look like and what that compounding effect might look like at the state level, which is what led me to my next study. So does your state of residence compound your risk for unmet mental health need if you already have other existing risk factors such as racial identity? So that led me to wanting to know, what does this look like at the state level, the racial and ethnic disparity question. Racial and ethnic disparities in mental health service use and access to care among children are well established. I could cite more. These studies, these disparities have actually worsened over time, especially for Black children, despite changes in policies that would make you think that we would be doing better. So I wanted to look with this same data set and using very similar methods at what the size and scope of racial and ethnic disparities in parent-reported child mental health access is nationwide and for each state. And I use the same data set, I use the same outcome and control variables, many of the same subgroups, and I did use logistic regression with post-estimation marginal predicted probabilities. The ways that this little study was different from the first one is that observations for children identified as other or multiracial were actually excluded because there were not enough of that population in most states to adequately generate statistically accurate estimates. This was recommendations, based on recommendations from the survey itself. Also, models that assessed disparities between Black versus white children included only 23 states and the District of Columbia, with a sample size significantly smaller of 5,900 children. And that was because also as well that there was a critical mass of Black children in certain states that just did not reach the numbers needed to be able to generate accurate, statistically accurate or representative estimates. And then for similar reasons, the models that assess disparities for Hispanic versus white children included only 40 states and the District of Columbia, and the sample size was a little over 10,000 children. Slight different modeling difference was that I included an interaction term between state and race or ethnicity, and the predicted probabilities were generated for each racial or ethnic group for each state. And then the size of the disparity was simply mathematically generated about what's the disparity the disparity was estimated by a mathematical, just subtracting what the estimate was for white children and what the estimate was subtracting what the estimate was for the racial or ethnic group of children from the white estimate. So that resulted in, if it was a positive number, Black or Hispanic children were more likely to experience the outcome. So they were more likely to experience unmet need, or they were more likely to experience difficulty accessing mental health care. And if it was a negative number, then it meant that white children were more likely to experience the outcome. So this is a much more empty map, because the sample with Black children, estimating disparities for Black children and white children, only included 23 states. And for both unmet mental health need and difficulty accessing mental health care, you can see that Texas is pretty dark orange. And unexpectedly, New Jersey has pretty large disparities in Black versus white unmet mental health need for children. I have some thoughts about that. So this is the state-by-state view, very similar to the images I showed you in the very first study that demonstrates or compares the disparity in both direction, positive or negative, to the national disparity for Black versus white disparities in access in unmet mental health need. And the asterisk and the little teeny tiny cross, I'm not sure what those are called actually, shows what the level of statistical significance is of the size of the disparity from the national estimate. So in difficulty accessing mental health care, we see a lot more reverse disparities, which was actually a little surprising to me. And one state that stands out in particular as being significantly different in the Black-white disparities in difficulty accessing mental health care, and that state is Texas. Quite significantly different from the national estimate. So what did it look like for Hispanic-white disparities? So we included 40 states in this sample, so we have a little bit more visibility. And you can see some consistency between states that had higher rates of larger disparities in unmet mental health need and larger disparities in difficulty accessing mental health care. And this gives you the state-by-state breakdown in the exact same way. If you actually look, the unmet need, the disparity between Hispanic versus white unmet need for mental health care is almost zero at the national level. So that's notable when you see how much it varies across state lines. And on the far left, you see several states that have statistically significantly larger reverse disparities in unmet need for mental health care, and fewer on the farther side that have statistically significant differences from the national mean. For difficulty accessing mental health care, you see a little bit more variation. Again, Mississippi, I think this is the first time Mississippi shows up. But if you notice, it's hard to see, and it's like you could do a bigger chart, and we're talking about so many different states. But what is notable is that a lot of the states are, you may have Hispanic white disparities in one outcome, but not in another outcome, or you might have reverse disparities in one particular outcome for one group, but then not terribly bad disparities and not terribly different from the national mean in other states. So food for thought. These are all things that I assume if you want, you can pull the articles, and these are all in the articles as well. So my conclusions are that consistent with existing research, Hispanic white disparities are quite smaller than Black-white disparities. Across states, disparities for both groups varied widely in size and directions. Caregivers of white children reported more access difficulties and unmet mental health needs in some states, and caregivers of Black children and Hispanic children reported more of these difficulties in other states. Several states, surprisingly, had quite notable reverse disparities, where white children were having more difficulty accessing mental health care. And this was more common among caregivers of Black children than of caregivers of white children, or vice versa in some states. So there was just no pattern, and it's hard to discern any real consistency, and it makes you realize how much variation across these states exists, which is a great evidence of what we could study, because there's clearly a lot of different variables in a lot of different states affecting these findings. Most importantly, that these variations across states and variations across racial and ethnic disparities across states are obscured by the national averages that we use to talk about these problems. And they're particularly important to unpack because these are potentially compounding problems, as I said. If you're a person who's at risk for not accessing mental health care because you have more complex needs or because you have no insurance, if you live in a state that by itself has higher rates of unmet mental health need, how does that compound your risk for having unmet mental health needs? Are your odds of accessing mental health care reduced even further in those states? Uh-oh. No, it's not going. So there's a million drivers that could possibly be at play and things that could be examined. There could be geographic variation. In fact, we know there's quite a bit of geographic variation in the supply of behavioral health providers, the characteristics of behavioral health providers, and the cultural competence of behavioral health providers, and that looks different in different places. There are state policies that can impact who becomes a mental health provider, how easy it is to become a mental health provider. Another factor that's important to think about is that Black children especially, but Hispanic children as well, are disproportionately represented in social programs, that at the state level, many social programs that address vulnerable children's needs, including the foster care program, the juvenile justice program, as well as, of course, Medicaid programs. There's a huge amount of behavioral health services, education, that's another major sector, that provide a lot of behavioral health supports through these programs. Those programs are very strongly shaped by state decisions and can look very, very different across states. So I think it's an important area for investigation that really hasn't been looked at that much at the policy level in terms of what are the policies in social programs like foster care and child and family services and justice programs, and how does that shape access to mental health care differentially for these populations? And then, of course, there's a huge amount of variation in state policies that are related to health, things like the Affordable Care Act. We have the essential benefits that came along in that, and how that is enforced is different from state to state. We've seen some studies that have demonstrated that. There's also different enforcement and policies around the early and periodic screening and diagnosis and treatment plan, the EPSDT mandate that Medicaid has, that is enforced differently, and the guidelines for that look different in different states that could affect access to mental health care. And of course, at the district level, as well as at the state level, schools vary significantly in how many resources they have for providing mental health services, how they identify children for mental health services. So there's a multitude of things to study and to look at this for children. And really, there haven't been a lot of studies that examine the social and political drivers of mental health disparities for children. The two studies, when you put them together, are rather interesting because you can see that Texas has high rates of difficulty accessing mental health care and large Black and white disparities as well, whereas New York, the rates of unmet need for the whole state and the rates of difficulty accessing mental health care are not significantly different from the national average, but reverse disparities are quite significant for Hispanic white differences in unmet mental health needs. And there's quite significant disparities, reverse disparities in difficulty accessing mental health care between Black and white children. And so the reverse disparity issue or finding is one that could be looked at more carefully. And my hunch is that Medicaid disproportionate qualification for Medicaid is probably a strong driver of reverse disparities because we know that Black and Hispanic children are overrepresented in the Medicaid program. And we also know that the Medicaid program, at least for children, is a pathway or a gateway to robust mental health services in a lot of states, not in all states. Let's see, Wisconsin, unmet mental health need was not really significantly different from the national averages, but reverse Hispanic white disparities are quite significant. So I think when you look at the two things together about what does the state look like overall, and then what do the disparities within that state look like, I think there's more to unpack and a whole research agenda that lies ahead. There are several limitations in this. There is no causal inference. I did not investigate what any of the drivers of these disparities or these differences were. My goal was to simply note that these differences exist to lay the groundwork and motivate future work in this area. Another limitation is that all of the measures in this survey rely on caregiver report. As a social worker, though, I'm very committed to centering the lived experience of caregivers and children. And so my view is yes, there are many people that would argue that we did not have clinical measures to determine if these children had mental health need, but I sometimes question how important that is if a parent thinks the child has mental health need. And also, we used a measure of mental health service use that was exclusive to identifying if children received services from a mental health professional, and it does exclude a population of children that may receive mental health services from their primary care provider primarily. And also, because of the small sample sizes, there may have been statistically significant differences in some of our estimates of disparities, but the small sample sizes made it harder to detect. The sample sizes, I only included states that met the threshold that were recommended by the survey, but I do think if I used more years of data or larger samples, we would probably see some differences. And there's my references. Questions? And these are the two papers that have just recently been published. And that's it. Did I make my time? I think I did. Okay. Oh.
All right. Oh, we already got a hand up.
Well, on the issue of parental assessments, I think it might be an interesting study to look for the correlation between the degree of mental health needs assessed by parents and the characteristics of the parents, and kind of go backwards on that and see how, if there really is, which would help verify the quality of these assessments and consistency.
Yeah, I think that is a really interesting, that would be a really good, that'd be a good step. I love it.
First of all, Genevieve, thank you so much for being here and presenting your research. I find it fascinating that it is such a big sample size. And like you mentioned, more recent data is really needed, especially as an MSW student in practicum doing the work on the ground. We know how much these data are needed to justify the services we provide. As for my question, being an Asian American woman and also working in an agency that is mainly AAPI serving last year, we noticed that there is a big lack of data when it comes to mental health within the AAPI community. And I think for your research, it particularly stands out because a lot of the youth that are receiving mental health services who are of AAPI background, they're receiving it in school, and at least from this anecdotal from the clients I serve. And a lot of the times parents do not know they're receiving the services because of how big of a stigma mental health issues are. So I'm just curious,
That's a great point.
Yeah.
That what maybe a child's receiving it, especially at school, and the parent doesn't know. That's a great point. Yeah.
Yeah, I was just wondering if you were to give recommendation for future research, how would you recommend exploring this mental health inequity from the perspective of maybe youth who are kind of not being represented in your study?
I think there's a lot of youth not being represented. And absolutely the AAPI community is one of them. And I mean, that's actually one of the concerns I just have with the field in general, is that we don't have good enough surveillance methods to really understand what mental health looks like for children, really in any sort of granular way at all. The National Survey of Children's Health is one that I use primarily because it's the only survey that captures mental health for children under 12. Most data sets that have youth mental health variables, they only have variables for 12 and up, as though children only develop mental health needs when they are 12. So, so that's one population. That's why I use this data set, although I think that the population you're concerned about is underrepresented in most data sets. I think that one area that I would hope you could maybe see more about utilization, at least, which is not the same as unmet needs, is Medicaid or other healthcare claims data. The race and ethnicity identification of users in that data is fairly intact from what I've seen recently. But to me, it's not a whole picture because we just know if someone's used services, we don't know if they needed services. So we don't really actually have a very good way of measuring unmet need broadly. And another thing that's wrong with this survey that I'd like to point out, because I really care a lot about youth with complex mental health needs, is that this is an uninstitutionalized population. And children with the most complex needs are probably not included in this sample. I don't know if I answered your question. Okay. Sure.
Thank you so much, Genevieve. I realize you have limitations in your survey. Do they capture rural versus urban location at all?
There
I'm wondering-
is,
I
but
was
it's
thinking
not-
about your reverse
Yes.
disparities and whether that is.
That's a great point. I don't usually use it because it's not there for every state, because in certain states they suppress that variable for confidentiality. That's why this could be interesting to repeat this or look at it more deeply with other kinds of data.
I know it's hard to say because it looked like it didn't change that much, but between the two, for study one, between 2003 and your most recent estimates, any notable changes that you noticed just descriptively? You know, I know you presented the
Right, and they used different data, so you can't actually compare it to what, you know, between my estimates and their estimates. But honestly, no, I think the most thing that surprised that I guess I was surprised by is that the rates in general haven't changed that much. Like we haven't really moved the needle since 1998 in unmet mental health need.
So you don't think we have enough states where we could say we were a changer? A change, it's just overall. There's no outlying change states that you noticed.
I don't think so, but I'd have to go back to that first study and look. But I also think it would be my other beef with data and surveillance of children's mental health is that we don't know, because the National Survey of Children's Health operated intermittently prior to 2016, and then they did a redesign in 2016, and you are not allowed or able to use estimates from post 2016 to prior to 2016, and that means we have no way to actually track mental health outcomes for children and youth over time at this point in the United States.
May I take the liberty of asking an add-on question?
Sure.
No, now I forgot my add-on question.
That's good. The scooped study? You mean that, oh, they did a little bit, they just measured service use. So if they said, yes, I did use mental health services, as opposed to what I think is what I was more interested in is who's needing services that wasn't getting services. So that's how it's a little bit different. And they didn't look at difficulty in accessing care, which I think is an important granular thing to look at.
All right. Well, thank you once again, Dr. Graaf. We will go ahead and do a quick transition while we go to our next speaker. And yeah, we will be right back.
Thank you, Dr. Graaf. Thanks again to those who have joined us online. Our next speaker is Dr. Cuellar. Please take it away.
I think I'm Mike.
I keep, no, I shouldn't even try to manage the microphone.
And as have the others, I want to express my gratitude both to Susan and Alice for including me in this marvelous symposium event and honoring Lonnie's legacy. I'm here to talk about the safety net and its recovery post-pandemic. This is work in progress, so I have two different studies I want to share with you. But first, I want to share a couple of things that I learned from Lonnie. One is multidisciplinary work. So I've listed several of the co-contributors on this work. Lonnie was also the person who taught me how to write NIH proposals, and I am acknowledging gratefully the support from NIMH, NICHD, and the National Institute for Healthcare Management. And among this crowd are students that I hope I'm mentoring, even a fraction as well as Lonnie mentored me. So I want to talk about the pandemic and safety nets. So this is 5 years ago, folks, but under the public health emergency, there were closures and financial strain. So institutions had to close their elective surgeries, their elective procedures, their outpatient visits. And even though those closures didn't last for a terribly long time, there was a fair bit of reluctance by providers and by patients to return to normal levels of care. At the same time, mental health in the population declines, higher stress, higher anxiety, depression. And so the question is, how did the healthcare system respond? And did it respond in ways that generated disparities, right? So your healthcare system that's under strain, you have greater needs from essentially a new patient population. How do you manage your queue? Who rises to the front? Who ends up at the back? So, in the first study, we're focusing on children. And it's important, I think, to understand that in other studies, there's a documented demand for, there's a rising demand for care. So in 2022, so this is a couple years after the beginning of the pandemic, you had close to 20% of adolescents experiencing a major depressive episode. And many schools still remained closed for in-person instruction depending on the age group and depending on the part of the country. At the same time, treatment capacities fluctuating, right? As I said, we had short-term closures of all but the most essential healthcare services. And then we start to see some return. We do get a large boost from the federal government on the order of $180 billion going to providers to make sure that they're not financially strained, and that's not keeping them from standing up those services. And telehealth expands, right? Telehealth had existed, but its reach was far, far greater during this time and sustained. And then we also had rules under which more providers could prescribe medications. You could prescribe across state lines. And more providers were permitted, for example, to prescribe medication for opioid use disorder, right? So we loosened up these things to help enable access when access was incredibly difficult. And many of these things were sustained for a relatively long period of time. So we have other literature that shows that adolescents' emergency visits for mental health concerns rose from 2019 to 2023. So this is looking out several years past the pandemic, particularly for females. They dropped, though, for younger children. For anxiety and depression, we have sustained increases in prescriptions relative to pre-pandemic, but prescriptions for ADHD, not so much, at least in a commercially insured population. And then even before the pandemic begins, we have these widening gaps in treatment rates, both for internalizing and externalizing conditions between white youth and Hispanic and Black youth. So this is kind of laying out some of what we know contextually. So the question we were trying to address in our study, are certain youth disproportionately disadvantaged by these pandemic-induced strains on the healthcare delivery system? And the children and youth we select are those who are already in treatment for emotional disorders, right? So there they are, they're being treated. Where do they land in the queue, if you will, of a system that is trying to cope and faces increasing demand? And then children and youth who have adverse childhood experiences, including homelessness and abuse or neglect. And so what we're looking at is how are these primary care mental health treatment rates, meaning mental health services delivered by primary care providers and mental health services delivered by especially mental health providers and the mental health prescriptions. And the context in which we look at this are 300 community health centers across 14 states. It's the OCHA network. In this sample, 8% of the children experienced homelessness and 3% experienced a diagnosis of abuse or neglect. And we have, 150,000 children, I think. Because these are community health centers, we have an uninsured rate of about 15%. So nationally, most children are insured, right? We're well above 95% of children with our Medicaid expansions. But in this context of community health centers, we have 15% who are uninsured and 70% who are covered by Medicaid, so also higher than the national average. Now, here's something I want to point out, and this is a departure from the approach that we've seen in the studies so far and in many of the studies that Lonnie authored. And so two things. One, under the leadership of Lisa Dixon, who edits the Psychiatric Services Journal, we have a racial disparities editorial working group. And under that working group, in addition to things you would expect a journal to do to promote mentorship in submissions and editing and so forth, the group is also very focused on to please report the characteristics of your sample. So we don't end up with white and other, and not knowing who's in other. So even if you're not doing a heterogeneity analysis or subut or some kind of subsample analysis, it's extremely important for science to know who is in your sample, right? Even if you're not going to do a subgroup analysis. So in this sample, we have 16% Black African American or non-Hispanic, 33% Hispanic, 41% white, and very small numbers of Asian American Indian and a fraction where it's other unknown. But please, a plea to, sorry, I'm rattling here. Where am I rattling? I think if we just connect it to your jacket. Okay. Sorry, let me turn that off while I do this. There we go. Okay, good. All right. So a plea to keep helping us understand who's being studied, right? So that we can understand better the context in which the interventions are being implemented and tested. We also, in a departure from some of the studies you've seen so far, do not control for race and ethnicity. And that's because the phenomenon and the experience of homelessness and the experience of being diagnosed with abuse and neglect are very hard to disentangle from your racial background. And so by controlling for it, we're sort of controlling for part of that phenomenon. And we did not want to do that. So we do not control for race or ethnicity in this study. So the spirit of the study, this is sort of a typical graph. This is the lead up period to the pandemic beginning. This is the first year of the pandemic, and this is the period afterwards. And the top graph is for females, 2 to 10 years, our youngest age group. And the bottom one is 11 to 17. And the sort of quick takeaway that you can see is that while for females 11 to 17, the system sort of seems to have recovered if you compare here to here, right before the pandemic to where we are at the end of our data, that's not the case for the youngest age group. And this repeats. It repeats for males, it repeats for primary care, and it repeats for prescription drugs. So while for the older age groups, and we look at older, we look at 17, 18, we look at 19, 20, 21, we see a reversion, but we don't see it for the youngest. Then we look at the specialty mental health visits by your status as being diagnosed with abuse or neglect or homelessness. And here is the left panel, the abuse, neglect, and homelessness. And I should say homelessness is a flag in the electronic health record. And that's how we capture that. At the top are the youngest, and then we get older, and then I left off the older groups after that. And here too, you see that for the youngest, we're just not getting back to where we were, right? And these are, I would arguably, the group we had before was the children who had been in treatment for emotional disorders. These are the ones who had a diagnosis of abuse, neglect, or homelessness. So where we are is in this finding that the mental health treatment in these community health centers has rebounded 3 years later in treatment and even increased for some of our female subgroups, but we see declines in treatment for the youngest children. We also in this study look at primary care, meaning primary care preventive visits, outpatient visits and to primary care providers. And are you up to date on your HPV vaccine, right, as an adolescent? And here we're seeing that in this case, we're seeing a return to pre-pandemic levels of care. And in fact, we even see an increase in the visit rate for children 13 to 17, although we don't see an increase for those that we have categorized as the most vulnerable. Where do we go next? Well, we're trying to understand the role of integrated providers. Some of these clinics have clearly a lot of primary care that they're providing. That's their sort of foundational role in the community. And many of them, though, have integrated behavioral health into their clinic operations. We want to understand if that was a driver of any differences in care patterns coming out of the pandemic. Some states moved to very flexible payment under Medicaid, capitation type payments, and then we want to understand the role of school closures. Our hunch around the youngest children really not returning to the levels of treatment that we might expect given the level of need that we hear about and is documented in the literature, that it may have something to do with this picture. Now, this is as of May 2021, but the variation in school closure policies across geography and across age group, elementary, middle, high school, we'd like to understand if that has any role to play in what would fundamentally be the referral mechanism to mental health treatment. So that's where we're going to go with that one. And now I'd like to tell you a little bit about the study we're doing on post-pandemic care delivery to pregnant women. We look at prenatal care, lactation support, and mental health screening. Similar idea. Let's just look at these things over time and understand the interruption at the time of the pandemic. In this case, we look at Virginia specifically. We collaborate with the Virginia Medicaid agency. We have access to their claims data. So this is, again, a predominantly low-income population that we're looking at. We look at a variety of outcomes, birth rate, prenatal care, C-sections, and so forth. And here we are doing the classic comparison because we don't believe that there's something driving the phenomenon, right, of necessarily of pregnancy, where we would worry about controlling for race, right? Here we really want to understand the differences between non-Hispanic white and non-Hispanic Black and non-Hispanic white and Hispanic. So there's an important piece of, I think, a bit of a surprise in the data, and then an important piece of context, I think, that comes into it. Nationally, let me start over. An important metric in the world of perinatal care is birth weight, right? And the rate of low birth weight among Black mothers is twice as high as it is for white mothers. So it's about 14% for Black moms and 7% for white moms nationally. When we look at our data, Black being the red line and white being the blue line, we do see that the rates are higher for Black women than white women, but they're in most time periods. So the shaded space are the confidence intervals. It's unfortunate that this is how the graph is generated, but that's how SAS likes to do it for us. And we haven't fixed it yet. But you don't see very many time periods when the difference is statistically significant, which is a bit odd. So we looked at this some more. And my hunch is it has to do with the opioid epidemic. So Virginia borders Kentucky and West Virginia, right, on the rural end of the state, where the population is disproportionately white. So neonatal abstinence syndrome is something an infant would have, but it's an indication that mom was using substances, right? And so here you see that the white rate of neonatal abstinence syndrome is much higher, and that may be why we see less of a difference than we might have expected among our low-income moms. And then the good news, so the rate is flat and much lower for Black moms, and it's much higher but declining for white moms. And then the pandemic, I should note, is this vertical line here. So we're going back 2 years this way and forward 3 years from March 2020. Then we look at C-section rates, and we're really not trying to say anything about the impact of the virus on birth outcomes. We're just trying to understand treatment delivery more. So we do have higher C-section rates among Black moms and white moms, and we haven't controlled for birth weight or any sort of medical indication of this thing, right? We do see an early spike for Black moms that we would want to explore with clinicians, like why might that be? Because it didn't happen for white moms. And we do see a big difference in prenatal care. So for Black moms, there was a drop, right? And I would say, I'm going to eyeball this and guess it was fairly, it's persistent relative to the pre-period, but they appear to be far more willing or have better access to, not sure which it is, to have prenatal care than the white women for whom it takes a while for it to recover. And I don't know if that's attitudes, patient preferences, or something about the delivery system, about where they seek care. Is this more urban? Is this rural? We haven't explored that yet. Lactation support is something that is, of course, important for moms. This is lactation support of providing breast pumps, which are covered services under Medicaid in Virginia. And here we have higher rates for the Black moms. We don't see much in the way of statistical differences. They are reverting back gradually to where they were. Telehealth, I mean, this is something we see in just about every disease category, a huge spike in the usage of telehealth. And it's great, it's falling, but it's not reverted back to zero. It's finding its place, if you will, in the delivery system. And then lastly, let me just, before I jump to this slide, ACOG, so these are the American College of Obstetrics and Gynecology has been recommending depression screening for pregnant women since 2015, both during and after, right? We're trying to catch it during pregnancy and after for the important phenomenon of postpartum depression. And I am somewhat sad to report that we are close to zero still for most of our moms. And it's so close to zero, it's virtually non-productive to talk about disparities in this context. It's just still a challenge. Contextually in Virginia, Medicaid expanded around coverage from 2 months postpartum to 12 months postpartum in November 21. But if you go back and think about the graphs, we weren't seeing big shifts at November 21. At the time, 26 states have done that. It's now at 49. This has been a very popular policy change in Medicaid. Doulas were covered starting in 2022 in Virginia. At the time, 4 states, now 27. And doulas are undoubtedly, undisputably, an invention designed to support, in particular, African-American women. That is the target group of the doula, which is like a community health worker. And it's someone from the community with lived experience And so I have a marvelous student who's doing a mixed method study, has interviewed doulas, is looking at data. These are sort of where you might find the doulas. And in Northern Virginia, Petersburg and Tidewater, if you know your Virginia geography, is where we have the largest African-American mom populations. So she has some wonderful findings around provider enrollment and promotion of services and engagement with policy. I think what comes next is a whole agenda of what the OBBBA Medicaid contractions are going to mean. And starting in 2027, this is the large retrenchment of Medicaid to the tune of billions of dollars, and what that's going to mean for disparities, both for the children and for the pregnant women. The work requirements won't impact pregnant women, but they will certainly impact families with children above a certain age cut. And so there is a rich set of policy studies to be done, trying to understand both how to support the children and the community health centers and how they will fare under these new policy changes. So that's where we're going with these. And to close it out, I just want to express my gratitude once again to Lonnie.
Right, any questions?
We have an obstetrician in the audience.
On the children mental health first study, I feel like community mental health centers are a very specific source of, and those are CHCs, not FQHCs, or maybe some of them are both.
Yeah,
Okay,
I mean,
but not CMHCs.
No, it's not.
Okay, so it's not CMHCs.
No, we excluded I don't know that Ocean has mental health only, but we wouldn't have included them if they did. Yeah.
Okay, so what was the reason that you wanted to look specifically at community mental health centers, and
It's
who
the
was like what
safety
kind
net.
of care was left out of that?
Yeah. Oh, that's a very good question. So we wanted to look at the safety net, and I really wanted, honestly, a source of data that would help me understand phenomena like homelessness, which is really poorly documented in claims. And this is an electronic health record data set that tells you about homelessness. And we wanted to understand better whether, and this is kind of coming in the next steps, this flexible payments that these community health centers were provided helped them respond better to this just an immense disruption to care delivery, along with the integration of behavioral health. If you were integrated with behavioral health, did it help you get back up on your feet, if you will, as a clinic? So in my work, I'm focused on providers frequently. And so that's kind of the lens through which we were looking at this. Yeah. I think another interesting area of exploration is going to be a set of policies that's been in place for a couple of years to promote the use of mental health institutions for children. And the literature has been very unclear as to whether this is a desirable direction from a policy standpoint or not. But in 2018, we did expand the use of institutions for treatment for children with mental health disorders. Yeah. So, but that's completely outside the realm of these particular studies. These are mostly descriptive, trying to understand when and where did the system recover. And I think encouragingly, the results are, it took it a while, but we got there, right? In the face of a giant increase in mental health demand, right? Except for small children. And then the exploration is going to be where do we go with that? Yeah. But the children, we also have a study of children who are LGBTQ. And there we do find some age differences, and some kids who we don't have the youngest in that study, but we do have some age groups that are still falling behind. But the system, and we can't say because the provider relief fund was a national policy, we're not really able to, we don't have, clinics that got it and clinics that didn't in our state. We can't really do comparisons of the impact of the provider relief fund. But it's to the extent that provider relief fund intended to help clinics get back to where they were, we achieved that policy goal. So I think all in all, it's good news.
This is going to ask you an impossible question, but you did invite it in your last slide about forecasting a bit, about Medicaid and the safety net to come, and perhaps, yeah, what are your biggest worries that we might be thinking about for the immediate future? That's a hard question.
Oh, it's incredibly hard. And we're waiting, right, for states to respond. States have been, their ability, so the federal share of Medicaid is going to come down, and that's going to ask states to step up and contribute more. Some of the expansions that we've seen were really largely federally funded and funded with financing mechanisms that really allowed the states to put in as little as possible, right? So now it'll be up to them to make that a priority. And I do worry about the safety net. There is a nod to rural areas with some money. Is it going to be enough? I don't think we know. I think financing pressure doesn't bring out the best in our policies relative to minoritized populations in the safety net.
We have a question from Zoom from Dr. Angie Perrone, who is a faculty member here. Excellent presentation. Thank you for your work. I was hoping to learn more about the variable for homelessness. Was this self-reported from a parent, guardian, or a provider, or others?
Oh, that's a great question. It is a field in the electronic health record. And so it is something the provider would have turned on, but presumably in response to a conversation with a patient and or parent, depending on the age of the patient. And we, in our study, if that flag was ever on, we treated it as on, right? So that we didn't treat homelessness as a point in time experience, but rather somebody who was on the edge of homelessness at any given time. So presumably if you were homeless in this year, you were probably close to homeless the year before and not far from it the year after, right? So.
I would thank you, Dr. Cuellar. I'd like to introduce Doctors Accurso and Cordell for the next presentation. Thank you.
Okay. Is this on? Yes. Okay, great. I feel so honored to be here with this group of amazing speakers and with Kate to be able to co-present on some work that Lonnie really provided a roadmap for, and that really wouldn't have gotten done without him being able to kind of help me walk through what the next steps would be. So thank you so much for the invitation, and thank you so much for organizing this wonderful symposium. I'm Erin Accurso. I'm associate professor at UCSF in the Department of Psychiatry and Behavioral Sciences, and I'm clinical director of the Eating Disorders Program. And this work is something that I've been really passionate about for a very long time, but it really took Lonnie helping me figure out where to shape the work and where to go. And I remember going back and forth with him quite a bit about which data set was going to be the right data set to answer the kinds of questions that I was really interested in. And I remember when we landed on Medicaid, he said, Medicaid is a beast and it's going to take a long time to get it done. And are you sure you want to go that route? And then I remember being in his office a couple of years later, and we were still trying to get the Medicaid data. And I said, Medicaid is really a beast. And you warned me, Lonnie. And he sort of chuckled and he said, I know, but we'll get there and we'll figure it out. So just it's a really nice culmination to be able to present some of the work that we've embarked on. And Lonnie connected me with Kate, who has been really instrumental in this work. So I feel really honored to be able to co-present with you, Kate.
Yeah, thank you. And I'm so lucky and honored to work with you as well, Erin. And I'm so glad that Lonnie connected us. Hopefully this is not echoing too much. Get that out of the way. So I actually, speaking of the Medicaid data being a beast, I actually prepared Lonnie's Medicaid data prior to ever knowing him at the state of California, where I worked for a very short period of time because I couldn't take it. But I did, in my very short period of time there, I did prepare Lonnie's Medicaid data set and send him back then the DVDs with the data on it. So when I did introduce myself, I did let him know I prepared your data. And he had been waiting for years for it. And I came in and whipped it out for him and then left. So there was a, I don't know, that maybe that was, and then I didn't even know, but later I ended up at Berkeley. It was probably 4 or 5 years later. And I, found Lonnie again and saw that he was still in the area of interest that I had, and took his class and stalked him until he took me on. And so I am Dr. Kate Cudell. I'm an alumni from 2016 here. I was here, so my last semester was here 10 years ago. And it's exciting to be back. Thank you so much. And I'm so glad to be here to honor Lonnie. I've been dying for this all year. To have a way to honor Lonnie. So I am associate at SDSU Social Policy Institute part-time. Things that I do there are like working with Tulare County to help them with their foster care system and their children wellness system between foster care and mental health. I do that part-time. I'm also managing director of Mental Health Data Alliance. It's my own LLC that I've had for, I don't know, since I started here. Actually, I needed a way to earn money. So I launched a consulting company and have been doing consulting ever since. And that's what's allowed me to work with Erin. It also allowed me to work with Lonnie with SAMHSA. So we did a several-year project with SAMHSA that I ran through my LLC. And I'll touch on that at the very end. As well. I also do needs assessments for like Florida counties and San Mateo County here in California, where we really do focus groups and you really get in there about what is the need of the community and where do the disparities lie and where are the special populations that are not getting the services that they need. And I am also vice president, and this is a full-time position, one of my full-time things of data science at Mindula. And Mindula is actually a really neat company that was started by a gentleman who was diagnosed with schizophrenia in his 40s. And he felt like the only person that treated him like a human was his social worker. And so he started a company, and it's got about 300 social workers that do mostly telehealth. There's a little boots on the ground, but mostly telehealth. And what we do there is I run the data science team, and we mine the Medicaid data for the health plans to find women who maybe are had some substance use in the past, are now pregnant, and we call them up and we try to help them abstain. We also help people with substance use disorders by finding people who are likely in the hospital from a complication of a substance use disorder, and then call them up and help them with their substance use. We do a lot with unstable housing and homelessness, and I developed an AI engine just this last quarter that will look for unstable addresses. So the AI engine will look in the address and see if it's a hotel, a motel, a park bench, 123 Main Street. Sometimes the Medicaid folks will write in there, staying with friends. It'll find those words. It'll know it's loaded with Google Maps. It knows where the locations are, and it's able to say, this is a shelter, this is a group home. And we can find people with unstable housing, call them up. And one of the things that Mindula is really great at is connecting them to housing supports. It's one of the best ways that we improve their health outcomes. And so anyway, we also do violence programs there. So again, mining that Medicaid data, looking for people who are repeatedly in the ER for injuries. And these are often people that are in unsafe domestic relationships, and we call them up. We don't lead with, hey, we looked at your data and we see that you are, might be in a domestic. We say, do you need help with your housing? Do you need help with your utilities? Are you feeling safe at home? And then we build a relationship with them and help them move from that unsafe environment to a safer environment. So it's kind of a really neat company that I'm like glad to be working for and working with. And then finally, I told Erin my introduction is going to be a little bit longer today because I don't know what I want to be when I grow up. I think that's probably what Lonnie had a hard time with me, pinpointing me down, and I still haven't figured that out. The last thing I do is I'm an entrepreneur. I started a company because I got a Zellerback grant to connect the child welfare data and the mental health data in San Francisco County, and did that and built technology to do that. But then when the Zellerback grant funding ran out, the technology stopped being used. So I built a company to do that everywhere so that we could connect data from different systems and share that information so that when kids were changing placements, that their mental health provider could get ahead of the impending crisis they would have upon that placement change in foster care. That is being rolled out across all of California, and every kid in California that's in foster care will now have their information connected to their mental health information. So that was my first company. I'm about to start my second company, which is going to take information from children's mental health electronic health records, including their assessment information and their clinical notes, turn that into a narrative using AI so that kids now can go to their IEP teacher and their foster care family and their mental health provider and their juvenile justice care providers and carry the same set of narrative of where their strengths are, what they've been working on, what their progress is, and that information can be shared and they can understand it as well. And thanks to AI, it can be in an A language so that their Chinese speaking grandma can understand what they're doing too. So that'll be the next thing that I'm launching. And someday I'll figure out what I want to be when I grow up. So go ahead.
Now we'll continue to collaborate together, Kate. And Kate always brings really, really awesome ideas from all of the various endeavors that she's done. So it's been a really wonderful collaboration. So we're going to be talking about some work that Lonnie really helped to provide a roadmap for on improving health equity and outcomes for youth with eating disorders, specifically within the Medicaid insured population. And eating disorders are serious psychiatric disorders that typically onset in adolescence or early adulthood. Sometimes people think about eating disorders as really being kind of a niche area. This is really not a niche area. It affects about 10% of the population. And these disorders are associated with very, very significant medical complications, as well as severe impairment in functioning, as well as quality of life. So they really can be just incredibly disabling. And in addition to just impairment in life, they're also quite deadly. So eating disorders have a very high mortality rate across mental health disorders, second highest only to opioid use disorders. So it really is kind of a quite severe population that we work with. And the problem that I was really interested in trying to address is that there's a massive gap for young people with eating disorders in terms of accessing care. And this gap is much bigger and disproportionately impacts people with public insurance. And what we see, without early intervention, it really, youth are at risk for a more severe and enduring course of illness that really becomes increasingly difficult to recover from. The longer that people have an eating disorder, the more challenging it is to ultimately reach a place of recovery. So early intervention with eating disorders is especially critical. And any delays in access to care really diminishes the likelihood of a good outcome. And anecdotally, kind of within all of the various systems that I've worked in, what we often see with these kids is that they are admitted to the hospital. They are there for kind of a normal hospitalization for medical complications related to their eating disorder. They're often discharged without a great plan for follow-up care. We work really closely with the counties to figure out who can they see and how can we make sure that they have access to good outpatient therapy. And counties often look at us and say, we don't have anybody. We don't know what to connect them with. They're really doing their best. And there's just not a lot of expertise in eating disorders in the community settings. So they're often discharged without access to outpatient care, much less specialty outpatient care. And it kicks off this really vicious cycle of hospitalizations where kids are in and out of the hospital, their illness gets worse, they require higher levels of care, and becomes increasingly difficult for then, when we finally are able to help them access good outpatient care, for that outpatient care to be effective because the course of illness has been going on for so long. So I was really motivated to understand more about, who within our state, who are these kids? What do their services actually look like from an empirical standpoint? Because we didn't really have those data. So I think there's been this longstanding myth, in our society that eating disorders primarily affect affluent white girls, and the data just does not support that at all. But this historic stereotype is so strong that I think oftentimes when we're thinking about how to better serve this population, even within the scientific community, people will say, well, are those kids really there? Are you sure? I'm not sure that you're going to find those kids in the Medicaid insured population. So there really was kind of a lack of information, despite lots of information from lots of different epidemiological studies. There wasn't a lot of good fine-grained information about who was presenting with eating disorders within this community. And one of the postdocs who has also contributed to this work has also done additional work looking at disadvantage and seeing the big impact that has in terms of risk for disordered eating in youth. Risk for eating disorders is really multifactorial, including factors like food insecurity, stress, prejudice, community violence, as well as genetics. But what we see is that the rates of eating disorders across racial and ethnic groups and across socioeconomic levels is actually relatively comparable. But we see rates increasing more rapidly for people from lower SES backgrounds. So I think probably most people in this room have this context, but this was some of the context that Lonnie really helped me to better understand, which is that Medicaid pays for most of the mental health treatment that's provided in the US. And I think that's kind of an important context because not a lot of research is looking at that context of care, but that is the context of care that's providing the most mental health treatment in this country. But the mental health providers for eating disorders specifically who work in these types of settings generally don't have a lot of expertise. They usually don't have a lot of access to training in eating disorders. And some of this is based on kind of that idea that eating disorders is sort of this niche area, despite them affecting about 10% of the population. And part of this, I think, is also based on these historic stereotypes of who's affected by an eating disorder and it not really being an area sort of relevant for kids with public insurance. So I think that perception from both clinicians and administrators has really been present. And I think as a result, this population has really been underrepresented in treatment research. And so we don't really have a lot of data about these kids. And then I think it's also been really interesting for me kind of in my role as clinical director of the eating disorders program at UCSF. I've worked with a lot of different counties who sort of come and say, we're struggling, we don't know what to do, we recognize that we have this big gap in access to care, we're really working hard to try to improve things, we don't exactly know how to do that. And so it was really nice to have a pretty large group of counties get together and say, we have this problem, we need to figure out how to do a better job with eating disorders. And they met on a quarterly basis over the course of several years. And a lot of really interesting kind of discussions and findings from those meetings. But one thing that consistently these administrators and clinicians shared was that it was really difficult to build out a more specialized model of care for eating disorders treatment. And so some counties would end up working really hard to try to do that, doing lots of trainings, figuring out how to sustain that model. Other counties would say, we've tried that, it didn't work. We're just going to contract out with providers who are in private practice, who specialize in eating disorders, and figure out how to do that piece. But all of these counties working really hard to try to think about how to provide better care for kids with eating disorders, because when care does not go well, everything is on fire, and these counties are really struggling with what to do. So it was not uncommon for counties to say, that we have this member who is really decompensating, that they're in and out of the hospital, now we're needing to look at kind of a higher level of care placement for them. We don't have anywhere that we can send them within the network. And so they end up contracting with private higher level of care facilities for eating disorders treatment. The costs for these are extraordinary. They cannot be billed to Medicaid, so they come out of general funds. It's created a big, challenge for systems in terms of thinking about how do we adequately serve this population. And we'll talk a little bit more about kind of seeing some of that in the data potentially indirectly. So some of the importance of this work is that eating disorders are actually treatable. I think, again, there may be a perception about these disorders as being something that, treatment is not very effective for, but we do have outpatient treatments. They are effective. They're inexpensive. They don't work for everyone, as no treatment will across, all mental health disorders, but they do help, a large number of young people. And when we are able to implement some of these evidence-based interventions, we actually see a huge reduction in cost savings, mostly because we're avoiding kids, spending as long in the hospital and going back to the hospital. And again, as more time goes on and kids don't get access to timely care, it increases both the care costs and it decreases the likelihood that they will ultimately have a full recovery. And people end up relying a lot on the hospital as kind of a safety net and these higher level of care programs, which are really important programs to be able to sustain someone when they are, having a very difficult time and needing a lot more structure. But oftentimes the progress that's made there needs to be able to translate to kids when they're back in their schools and back in their homes and back in their lives. And so that's where outpatient care is so incredibly important. So this kind of prompted me to think about, how can we understand the Medicaid-funded system for kids with eating disorders and the kinds of services that they receive. And California was a really ideal state to be able to look at this in because each county manages their own mental health benefits. So we have a lot of variety in how counties end up doing that. So I sort of mapped out some of the various places where people can potentially fall off the continuum here in terms of accessing care. So we have on the left-hand side, our kids with eating disorders. Some of them will present for care somewhere, whether at school, to their PCP, or they may self-refer for care. Some of them don't present for care and then they might be missed. But for those who present for care, some of them will be screened for an eating disorder, some of them will not be. Of those who are screened, some of them will get an appropriate diagnosis, some of them, will fail to get that diagnosis. Even if they're diagnosed, we then, sort of have to figure out, are we able to help them get access to appropriate care? And that includes for eating disorders, both medical care and psychiatric care. You really need the both because of the medical complications with eating disorders. It really involves interdisciplinary collaboration to be able to provide effective treatment. So, and then once you get that, appropriate referral, you have to help in terms of people engaging in care. So there's a lot of places along this continuum where people can sort of fall off. And so as a first step, I thought to focus on if they're presenting for care, what happens at that point, and how can we understand that a little bit better? So I'm going to pass it off to Kate to explain a little bit about the mess of Medicaid data that we got and that Kate helped us to manage.
Yeah, I've become a little bit of a Medicaid data whisperer, I think, through my career. So Lonnie connected Aaron to me to help with the web of information in Medicaid. So we had requested a data set from DHCS. Aaron had, there were almost 5 million beneficiaries between 2014 2016 that had Medicaid. And what we wanted was kids who had an ED diagnosis, an eating disorder diagnosis, to do analysis on. But we also wanted a comparison group. So there was also a request for kids with mood or anxiety disorders or kids with psychotic disorders. And we got a random sample of around the same size as those. We get the full sample of eating disorders and then a random sample of the same size. And that was really DHCS's limitation of what you need for your study. Would have loved to have more data. It's also good to have more data, but that's what we got.
So what did we find out just initially descriptively about kids within the Medicaid system with eating disorders? So about half of the population with eating disorders was Latinx. Just under half indicated Spanish as their preferred language. And if you look at the population of kids insured by Medicaid, our demographics matched up relatively closely to what we would expect from the population level of kids insured by Medicaid. What I think was really striking for me in understanding, where these kids were, over the 3-year period of data that we got claims for, about half of the eating disorder diagnoses were completely unspecified. And these unspecified diagnoses are really intended to be used in emergent settings, like if someone presents to the ED and there's not time to basically do a diagnostic type of interview to provide a specific diagnosis. You might use this unspecified diagnosis. But over time, you would expect that at the next presentation to care or the following one, that diagnosis would be refined over time. It's not meant to kind of stick in your chart. But for those who actually had an initial unspecified feeding or eating disorder diagnosis, most of them never received a more specific diagnosis over the entire 3-year period. So I think this probably reflects some level of uncertainty from providers of not really feeling confident about making a more specific diagnosis. Makes it a little bit difficult for us to understand what that group that comprised of, about half of our population, what that group actually looked like. So I'm sure it was quite heterogeneous, and says a little bit about kind of the level of comfort that providers had in terms of providing a more specific eating disorder diagnosis. So we saw overall a pretty gross underdiagnosis of eating disorders among youth with Medicaid insurance, and Kate can share a little bit about kind of how we came up with these numbers, but it was, even with a very conservative estimate, we were really missing a lot of kids who should have gotten an eating disorder diagnosis in this population.
Yeah, so when we looked at the literature to see what the prevalence rate of eating disorders should be in the Medicaid population in California for the ages we were looking at and the years we were looking at, we were only seeing about 13% of what we should have been seeing in terms of kids with diagnosed eating disorders, meaning that 87% of kids who should have been there we're not diagnosed, we're not being seen, we're not being treated. And so when we submitted this to the reviewers upon publication, they really hammered us on this and made us come back to them 3 or 4 ways to show that that was actually accurate. So it was true in all the ways that, they tried to shoot bullets in it. It really was a very, very low prevalence rate in terms of people seeking treatment.
So then kind of to shift gears a little bit. So once somebody received an eating disorder diagnosis, I wanted to understand what actually happened from that point in terms of services that they were able to access. And we saw service utilization in the first year, kind of following the first diagnosis that we had, that about half of them were receiving no outpatient therapy at all. This is, somewhat consistent with other estimates for the, unmet mental health need for kids with Medicaid insurance. For eating disorders, that number was a little bit higher and significantly higher. About 61% of kids with eating disorders received no therapy at all. For the minority who did receive therapy, they received a very small number of visits, so about 6 visits over that first year on average. But they were actually engaging in care. So these kids actually were presenting for care. They were just receiving more medical care than kind of psychiatric care. So they were receiving about 16 visits on average over that first year of medical care. That care is really important, and is that medical monitoring and follow-up is really, really critical in the context of eating disorders. And we really expect it to be paired with the mental health treatment as well. And we didn't really see that for this population. And when we looked at kids with other psychiatric disorders like mood or anxiety disorders or psychotic disorders, they were also experiencing a high level of unmet mental health need, but kids with eating disorders were experiencing it much more so than these other populations. And again, kind of the hypothesis around this is that this has not been a population that's really been thought about much in the Medicaid space, and so they're probably having more difficulty accessing services.
And I even wanted to add that we even went back to DHCS and said, did you give us all the data about only being able to analyze 13% of the kids with eating disorders?
Right. Yeah. And then among those who were hospitalized, who had an eating disorder, almost half of them received no psychotherapy at all, either before or after the hospitalization. So, I think in my mind, I would hope that, once connected to a hospitalization that kind of recognized, the severity, the importance of this diagnosis, it might increase people's access to therapy. And we just didn't really see that happen. So, so then we got really interested in, how can we understand how some kids are able to access care and how to kind of change the trajectory that many of these kids are on.
Yeah, so we looked at the health disparities in accessing care, of course, in Lonnie's honor. And youth with EDs who preferred language other than English were less likely to receive outpatient care. Black, Latinx, and male youth were also less likely to receive outpatient care. Sex and race-based treatment disparities were greater for youth with EDs relative to youth with mood or psychotic disorders. And you'll see these on the next slide more visually. And then I don't know if you want to talk a little bit more about the family-based interventions.
Yeah, I think the other thing that we were really hoping to understand, because for kids with eating disorders, family-based interventions are really quite important. And primarily the kind of leading treatments for eating disorders in youth are primarily family-based. And so I was really hoping to understand, how many of these kids are getting family therapy? How many are getting individual therapy? How can we understand the balance here? So few kids were getting therapy that it was really hard to be able to look in such a fine-grained way. But when we kind of looked across diagnoses, across mood and anxiety and psychotic disorders, the kids with eating disorders were the least likely to be receiving family therapy services, when really family-based interventions are so incredibly important for this population. So again, just kind of an extra disparity for kids with eating disorders in terms of accessing appropriate care.
Yeah, and so you can see this is just generally what we were talking about in the last slide, but just visually over on the right side there. Oh, that's my right side. Your left side. Over on the left side there, you can see that with male as the reference, that females with AN and BN were about twice as likely to get outpatient care, excuse me. And then over here, you can see in terms of race, Black and Latinx kids were less likely to receive, with eating disorder, were less likely to receive outpatient care. However, you didn't see that disparity as much in anxiety or psychotic disorders, mood and anxiety and psychotic disorders.
So there is kind of this gap in outpatient care that we believe likely contributes to a relatively high hospitalization rate for these kids. Across eating disorders, about 1 in 5 youth had at least one hospitalization within that first year post-diagnosis. The hospitalization rates for kids with anorexia nervosa and bulimia nervosa were quite a bit higher, about 30%. And kids were spending quite a long time in the hospital in that first year. So on average, kids were spending about 30 days in that first year post-diagnosis, compared to the hospitalizations for kids with mood or anxiety disorders, which were about 10 days, psychotic disorders about 12 days. They were much shorter. And we were able to look at hospitalizations that were categorized primarily as kind of mental health related versus medically related. And those hospitalizations for kids with eating disorders that were primarily medical in nature were significantly longer. So they were spending about 2 months in the hospital if those hospitalizations were more medically related. Again, that was kind of on average in that first year. So if you just imagine kind of the level of disruption to a young person's life to be spending that much time out of their family, out of school, in the hospital, in and out, basically, it's just such a disruptive course.
And an indication that the 13% that we're picking up are the more acute 13%, and that everyone upstream is likely the ones we're not seeing being served.
That's right. That's right. So, some implications here, there were really significant unmet mental health treatment needs across Medicaid-insured youth, but these were most pronounced in the kids with eating disorders. And that those health disparities were really persistent even after youth were identified and formally diagnosed with an eating disorder. So, come the next thought, well, maybe hospitalization, we can learn something about the types of services that kids access following an initial hospitalization for connection to mental health care, because that's probably a trigger for the mental health system, not just on the medical side, but now on the mental health side. Okay, someone's in the hospital, let's figure out what to do. So we wanted to understand a little bit more about, what care looked like for kids when they were discharged from the hospital.
Oh, that hospital data. Oh, that Medicaid hospital data. What a mess. It was such a mess. It was different for every county, every provider, everything. Some had discharge dates, some didn't. Some were every day, some were every month, some were. So I ended up having to take all the hospital data, explode it into days, and then stitch it back together so we could get the actual time kids were in the hospital. But this was actually the most interesting study to design, because what we really wanted to do was see, once kids got out of the hospital, did they get follow-up care, and did that follow-up care prevent readmission? Well, if you've studied readmission, readmission is a really hard thing to get at, because you need an admission, and then you need time for exposure, and then you need to see if there was a readmission. But if they go back into the hospital in 7 days, did they have enough time for exposure, really? And are we going to count them? Are we going to include them? What are we going to do? So for this, what we did was we included 920 youth that were had Medicaid for the entire period of time that we needed, which was 180. No, it was 270 days. We needed them to be available in Medicaid for 270 straight days. So we had only continuously enrolled, Medicaid enrolled youth. So a little bit of a limitation there, that it won't be generalizable to youth that maybe are going in and out of Medicaid. And so we had 920 youth that we could look at in that way. And then we needed them to have been hospitalized. So that was, another subset of youth. So down to the 920. And then we used Cox proportional hazard model to see if in the 90 days after a indexed hospitalization, which I ended up stringing together multiple hospitalizations until they had at least 90 days post-hospitalization where they could have an exposure to outpatient care. So if you go to the next slide, so basically it looked like this. We needed a 90-day pre-period inpatient exposure, and it could have been more than one. And if they were back in the hospital within 30 days or 60 days, or they were before the 90 days, strung those hospitalizations together as a single index, that they weren't stabilized enough to be back in the community to have the exposure of outpatient care and be stabilized in the way that we wanted to evaluate. So that was the first step, stringing these in, looking if they came back in, nope, that's still the same hospitalization index. And then we would count all the days that they spent in that pre-period. And then we had our exposure period, which was that 90 days now that we've protected to allow for exposure. So now we're looking at how many outpatients did they have in that next 90 days that we've protected to allow for a dose of exposure of outpatient. And then we evaluated the third set of 90 days to say, okay, in this 90 days, how many folks returned to inpatient after they had some sort of exposure to outpatient. So it's kind of fun to design, and it was like a little bit of, jumping through hoops to get the data to conform to this. But if you go back one slide, I think we talk about the covariates. Yeah, so we had the index hospitalization. We adjusted for how acute they were prior to the exposure to outpatient. You can actually go in demographic characterizations and comorbid. We looked at instability in their physical instability. We had done another paper on that, so we had some other characteristics we could look at. And then if you go to the next slide, we split the amount of outpatient exposure up to be proportional to meet the Cox proportional hazards model, and that led us to 0 to 3 sessions, 4 to 8 sessions of outpatient in that 90 days, and then or 4 to 7, and then 8 or more sessions. The sad part about it was that only 4.5% of kids had 8 or more sessions, which would be like weekly care, weekly outpatient therapy in that 90-day exposure period, and that a large majority of the youth had less than that, and a lot had none, or 0 to 3. And then there was this other group that just perplexed me for the longest time. So if you go to the next slide, this is where we ended up. We have our or Cox proportional hazard model of readmission, risk for readmission, 8+ therapies, doing great. Outpatient. This we'll talk about in a minute. We had the 4 to 7 days and then the less than 4 days. So you see this nice dose response in terms of their exposure. It didn't look like this at first because we had this other group here that was mixed in with the less than 4. These kiddos disappeared off the face of the map. And they were mixed in with this group. So I wasn't getting that dose response. I wasn't getting anything proportional. And the model didn't look good. And I spent 2 weeks banging my head against the wall, trying to figure out what is up with this group? Why do they look so heterogeneous? And I finally looked at some other characteristics of this group in that they weren't going to the doctor anymore. They weren't going to the dentist anymore. They weren't going to the optometrist anymore. In fact, they had fallen off the face of the earth. These kids were still there. They were still getting some sort of treatment, not outpatient for mental health, but they were still in the system. These kids were gone. And so that's where, as Erin mentioned earlier, these kids were more than likely in another.
Yeah, more than likely in a higher level of care. And we see that relatively frequently. And this group of kids was about a third, a little bit less than a third of the sample. And it is relatively common for counties to contract with higher level of care eating disorder specific facilities. And because these are not built into the Medicaid system, they're not built to Medicaid. They're not really directly paid for by Medicaid funds. They're paid for with like general funds that are found from the heavens. But you don't get to see the care that's happening for that group because it's not actually directly billed to Medicaid.
Right, exactly. So it looked like they were getting no care. So once I flagged them as their own group, everything fell into place. But it took a while to figure out why does this not look right until we found this group, flagged them, then you have your dose response.
And I also just want to point out, I think these findings, the kids who received less than 4 therapy sessions, I mean, they were 25 times more likely to be rehospitalized than those who received the 8+ sessions. These weren't, specialty therapy sessions. These were the everyday sessions that were being provided in these public mental health settings. So, and what we know from these providers is that they generally don't feel that they have the training in eating disorders. So this was not specialty care. Like this was kind of the typical outpatient care that could be provided within these public settings.
And these are the kinds of results you dream about. 25 IRR, like 25x, 25 times less likely reduced risk of hospitalization versus this group here, and then you have a dose response. These two groups represent 65% of the kids. And then you have about a third, and then you have your little 5% up there that are actually getting the care they need.
So what are the implications of this? Hospitalizations are very expensive. Per youth, the estimated cost savings for 8 sessions of outpatient therapy versus 1 rehospitalization is about $70K. What this implies is in our state alone, if kids who were already hospitalized once, forget about the initial hospitalization, but already hospitalized once, if all of them were to receive 8 sessions, at least 8 sessions in 90 days, it's not even weekly therapy, the savings for the state would be about $7 million annually. And this increased therapy access could likely lead to additional savings because initial higher levels of care or initial hospitalizations would likely be prevented or reduced. So conclusions here, most Medicaid insured youth in California who have an eating disorder get very little to no therapy, even after they are hospitalized for significant medical or psychiatric complications. And that the effects of outpatient therapy on preventing rehospitalization are really dramatic. They're dose dependent. The more you get, the better you do. And they were independent of a lot of different covariates and moderators that we included in these models. So we really think about, how can we increase access to outpatient therapy for this population as being really critical to improve their outcomes and also limit costs. Really want to acknowledge Lonnie, without whose support, I would not have had this roadmap and would not have been able to pursue this, and without whom I would not have met Kate, who did a lot of magic with these Medicaid data that were way too messy for me to figure out what to do with. I also really want to acknowledge Megan McHale and Amanda Downey, some of our collaborators in this work together. And then also the funders. We had a really generous donation from the Deb family, from the Lisa Stone Pritzker Family Foundation, and also some funding from the NIMH.
And I just wanted to end with kind of a quote from one of Lonnie's papers. This was worked with Lonnie for several years with SAMHSA to create these amazing reports using the NISDA data to look at social determinants of health, race and ethnic disparities of untreated mental illness. And we spent 2 years making these 2 reports, and they were ready to go get published. And then 2016, 17 hit, and those reports never came to light. So instead, Lonnie stuck with it and published this paper with Juliet Bew from SAMHSA. And this was work that I did with him through Mental Health Data Alliance. And what you can see here in this, what we found here was that there's this double jeopardy going on, that untreated mental illness even has a racial disparity. So African Americans are 3 times more likely to be living in poverty among people with untreated SMI. And that you can also see just with mental illness status, there is a dose response. Then you add race on top of that. And it's what he was calling double jeopardy, is selective, but it does exist, doubly disadvantaging some minority persons with mental illness. Can you finish?
Only from a wide-ranging and vigorous effort can the special burden of impaired health and community functioning be reduced for ethnic minority persons.
I just love the passion with which he worked and how he just tirelessly went after, the things that he wanted to do and see. And this was several years to get to that point. So thank you.
Thank you.
Thank you both. We'll go ahead and switch to questions.
Can you say a little bit, I'm definitely not a clinician. Can you say a little bit about the comorbidities with eating disorders? Is there anything about those that might explain why the eating disorder isn't in place 1 or 2 in your diagnosis code space?
Yeah, when we conceptualize eating disorders, we really think often about the eating disorder as being primary, because it is so all-encompassing that it doesn't, it's really hard to prioritize. If there's mood or anxiety, if there's acute suicidality, that's obviously always going to be at the top. But the level of kind of dysregulation and dysfunction from the eating disorder is usually the primary target when there is an eating disorder present. And kind of surprisingly, we didn't see the level of co-occurring disorders that we would expect to see with eating disorders in this Medicaid sample. Usually we see a relatively high rates of mood and anxiety disorders, OCD, trauma. There's lots of co-occurring disorders that we often see with eating disorders. We didn't really see the rates that we would expect to with this population that we got from Medicaid. And I don't know that I totally trust that as being what the clinician maybe was conceptualizing as the whole diagnostic picture, because they don't often put all of those diagnoses into the billing data. So I didn't make that much of that picture, I guess. But yes, we do see quite a lot of co-occurring disorders in the context of eating disorders. Yeah, and the treatment of those is also really important, and sometimes happens concurrently, and sometimes happens after recovery, and sometimes isn't needed, because treating the eating disorder, sometimes the depression that wasn't really primary resolves because malnutrition resolves, for example.
Thank you, Alison, because I was going to go with this too and have you elaborate. So then you have this sample. So if there's something weird, obviously, and thank you for educating me, because I had also, unfortunately, the impression that this was an upper middle class female disorder. But given the patterns of comorbidities, is the Medicaid data, could you get hints in there from other Were some of them in the other disorder categories possibility in your random sample?
They were for sure. There weren't that many, but they were for sure. We removed those cases so that we didn't
Okay.
have overlapping individuals across the, comparison samples to our eating disorders population. But yeah, I don't know, Kate. It was not insignificant, but it was just a pretty small
Oh,
number of
small.
the
Yeah, we went from
8,000.
8,000 down to like 7,800.
Yeah.
Okay.
Yeah, there wasn't as much. You would expect quite a bit of overlap.
Yeah.
But again, we didn't have the full populations of kids with mood and anxiety disorders and psychotic disorders. It was just a random sample. So, some of those kids did pop up who were already in the eating disorders population. We took those kids out, obviously, to not have them doubly represented.
And then I'm going to follow that up. I have two follow-ups. I'm sorry, audience, but nobody was lifting their hands. So I took this over. What would be the typical course in an eating disorder about what the precipitating events would be? Like, do you see like declining, depression levels, et cetera?
Yeah, I think it's really heterogeneous and it depends on the presentation. But typically it takes people 6 months to a year, most often a year, to access care, oftentimes longer. Depending on the type of eating disorder, there could be a lot of different things that could be going on. If it's more of an anorexia presentation, there's also a lot of reasons why that might have come about. It's not, I think often there's a perception about body image really being the primary driver. But there's a lot of reasons why somebody might kind of start to go down a path and then it sort of unfolds and takes on a life of its own. With someone with binge eating disorder, it might have started as emotional eating and then, kind of becomes, more impairing and disabling. But I think it really depends on the type of presentation. But the kids who we ended up seeing most often kind of in the hospital with anorexia and bulimia, oftentimes we're seeing really dramatic changes in their eating patterns. For some, really dramatic changes in their weight and their nutrition status. And again, really severe medical complications alongside that. So they're often presenting to their PCP and getting medical care, but having a really hard time connecting to the mental health piece that's really integral for overall recovery.
And although glass half full, that a minimal treatment was helpful, what would have been the indicated? I bet what would you have liked to see? Like, here's the perfect pattern of outpatient.
Yeah.
Beyond 8 sessions.
Right. Yeah, most of the treatments, the outpatient treatments for eating disorders, they're not really that long. That's not to say that everybody only needs that number of sessions, but a lot of the manualized treatments may be around 20 sessions or so, and those are usually weekly sessions, sometimes a couple of times a week if it's more of an individual therapy model. So it doesn't usually take more than maybe a year of therapy. Again, some kids are able to do with less. Some kids are likely to need more. Some kids may switch from more of a family model to an individual model. But we would expect to see at least 10 sessions, more likely 20 for the cases that we work with, more locally in San Francisco County. Like those kids are probably receiving upwards of 25 sessions, maybe, where they're at a good place to be able to kind of wrap up therapy. Again, it's tough because it depends on the individual presentation and the family and the supports that are in place and all these other factors. But we would expect to see probably at least 20 sessions for kind of a full course of an evidence-based intervention. And what we saw was just so far from that, and not surprising that it was so far from that. But I think surprising that so few kids got access to any care at all.
Great presentations. I wonder how many of the eating disorder children can get help from telehealth, and among this group, would it be possible that they also get telemental health therapies. And I find that it would be actually a good way to closing some gaps. And especially just as I was educated myself that it needs to have a lot of like more sessions, and then actually engage in telehealth could also like if they don't need to actually travel to the place to do the intervention.
Absolutely. Yeah. And I know during the pandemic, especially, we saw a massive shift to telehealth services. And that really expanded access for families who would otherwise have a really difficult time coming in and accessing services, where, maybe one parent was here and one parent was there and they were both able to join. And sometimes one would have to leave early, but it really made it possible for them to come in for more regular therapy and actually participate more in the therapy process. I know that things are kind of in a process of shifting now post-pandemic with how much telehealth is being offered. A lot of the clinicians that we work with also do a lot of work in the homes or in the schools, and so have thought about ways of making services more accessible in that way, and not just like you come in here to the office, but we go to you and can provide some services in the homes. And so I think there's more innovative ways of thinking about how care can be delivered than kind of the typical office-based face-to-face psychotherapy hour. I think digital interventions have an important role in kind of, future mental health interventions, including for eating disorders, and certainly more expansive models than kind of the in-person office-based therapy model that is not accessible for a lot of people. So I definitely think that's an important research for future directions.
I have a hypothetical question. If you wanted to engage more with your Medicaid data, there's a quasi-experimental design where you compare people in treatment to people who will be in treatment in the future. Is eating disorders one of those where you can sort of presume that if you're going to be treated in the future, you're somebody who is at risk or in a state of having that disorder? And then you could plausibly compare, at least on the medical side, the impacts of the treatment, right? So you have a treated and an untreated, where you have a sense that they both have the same disorder, but one is treated in the future.
So this would be like for two people with eating disorders, they both have a diagnosis.
The problem with claims is you don't know they have an eating disorder until they're treated, right? They get a diagnosis. So this is somebody who's going to be treated in the future.
I see what you're saying.
And they get your 8, 10, 20 visits, whatever you think is the treatment that you're trying to understand and its impact. So you compare a person today who has the course of, let's say, 20 visits, and you compare it to somebody who's not getting them, but they will get treatment in the future. But you want to know that they're likely to have an eating disorder now. So you're not comparing eating disorder to no disorder. But I don't know how quickly an eating disorder comes along.
Yeah, I think our biggest challenge with that is that we're dealing with the 13% highest need kids that are in the hospital for 60 days. And we don't have any sight lines to anyone who would be upstream from that.
Yeah, it's a really interesting question because a lot of my thinking around this is how different the trajectory could look if someone accessed outpatient services sooner. But at least from the Medicaid claims data, we don't really know that they would need to access services until we kind of have that diagnosis flag. I think with more longitudinal data, we could see what someone's trajectory looked like leading up to the eating disorder diagnosis, but when it onset, would be a guess. Be really hard to know whether they had been ill for 3 years and were now presenting for care in a different way, or whether this was a recent onset, they were just admitted to the hospital and now it was just identified. But it's a really interesting question, one that I'd like to think more about.
And I think that the take-home message really is that Medicaid is seeing this as a physical health disorder, and they're treating it as a physical health disorder, and they're not treating it until there's a physical health problem. And so that's why there's not a whole lot of mental health outpatient therapy pre or post.
Genevieve?
Final question. Okay. So first of all, I want to say I love that you did this thing where you found kids that we think maybe
exited the Medicaid system for a minute. I did wonder, were they still did you have an indicator that they were still enrolled in Medicaid, but just were not using services? I think that's I think you should just do a paper just on that as a methodology, because I think as someone who thinks about kids with complex mental health care needs, and I think about how do we know who's in the residential system, because the residential system is a lot like the ED system, where tons of it is privately funded and people are mortgaging their homes or cashing out their college funds to pay for that care. And I'm consistently stymied by how do we know who's experiencing that? And there are other complexities to it. So I just wanted to say that I really, really liked that. That's what really stood out to me from a methods perspective. But also I wondered if, from a policy perspective, if you were thinking about, I hear that your main concern is outpatient care. That's great. Love it. But is there any sort of concern about providers should maybe be taking Medicaid, and why aren't they taking Medicaid?
I mean,
I just wonder if that's something that I feel like we are always like, oh, what can Medicaid or public systems do better? But I also think there are people that have these skills and they are not sharing them equitably. And so I was just curious if you thought about that, or what your plan is to think about that, or explore that in any way.
Yeah, it's a great, it's a very provocative question, Genevieve. So we do a lot of work with providers who work in kind of these public mental health settings. We do a lot of trainings. And some counties have sort of taken the route of, we need to figure out a way to build up this expertise within the counties themselves. And others have said, you know what, we don't have this expertise within our counties, and it's really hard to build it. And so they have taken more the route of, let's go out and find these providers and make those connections. And oftentimes, I mean, just anecdotally, I think these providers are really eager to provide services to a more diverse group of kids, and are willing to kind of talk to counties and figure out how to make that work. But it's so time intensive to do that. And it's so dependent on the system. I think in states where it's a state run Medicaid system, it's much easier to figure that out. I think in California, where each county is basically, the Wild West and doing their own thing, I think it becomes much more challenging because they all have a different view of how they think it should be done. And I think this is my challenge with like the mental health field in general, is that the insurance reimbursement is not adequate. And so a lot of people do leave the space where they're serving kids who have insurance because, they want to work in a different type of system. And that kind of system is not the reimbursable system. And I have my own thoughts about that. And, it's an important part of why I'm at UCSF and at, Zuckerberg San Francisco General, and because that's a core value of mine. But I also understand sort of the realities of insurance reimbursement not being adequate for people's time and training.
But California's not doing anything about that.
No.
And all this other money on private contracts.
Yeah.
Oh my God, you generated a lot of interest.
Who is providing the care? Is it MSWs? Is it?
Yeah. In California, it's going to be mostly MSWs, MFTs.
Is it the case that there's inadequate training? I'm not trying to be mean. At places that train MSWs on ED?
The graduate training programs, and it's not specific to master's programs, the graduate training programs for mental health, broadly, don't really provide a lot of training in eating disorders. And I think a lot of people coming out of those programs, again, whether they're doctoral level programs, master's level programs, do not feel that they really got, maybe they got one lecture. So it doesn't really matter what level of program you go to, generally, unless you decide to specialize in eating disorders and seek out those opportunities. And even when you do, I think still sometimes it's quite hard, but it's not built into the training. So yes, I do think that's a big gap, that if we can build more of that into the training with the understanding that these are people who you're going to see. You're not going to be able to avoid eating disorders because it's this niche area. These people are going to walk into your office, and it's important to have some knowledge for how to help.
This is my point. If the dean of the school, and I didn't know this either. The only person that I ever knew that had this was an affluent white girl.
Right.
So if that isn't well known, then this kind of descriptive data needs to be pushed out there and talked about and stuff.
One other thing I'll say too is that the screening assessments don't have any questions for eating disorders on them. None. They're like anxiety and depression and self-harm, but it doesn't
So
ask a single question.
And it's largely by design, Kate. And companies will say,
because they don't know what to do. If they
we don't want to know, don't tell us,
That's the
because we don't know what
importance
to do with you.
of such things.
So.
Okay. Our last but not least presentation will be led by Dr. Timothy Brown. Timothy or Tim, take it away.
All right, great. Can you hear me okay? Yeah. All right. So I should talk a little bit about how I came to this project. So this was a project R1 that was designed by Lonnie and Genevieve and Alison. I came in later. Lonnie called me up and he said, Tim, do you have any good doctoral students I can work with to help with this study? And I checked around. I said, no one's available right now. And then he said, well, might you be available? And I said, actually, right now I am. So he set up the paperwork, and here we are. So the study was originally set up to use the national sample of drug use and health. And we had to set up the paperwork to get into the restricted data, which took a long time. And I said, well, I don't have any idea how long this is going to take. So we talked about what can we do in the meantime, because we got to do something. So we decided to use the BRFIS, the Behavioral Risk Factor Surveillance Survey, to do this work. So this is joint work with all of us. And the original R1 was about insurance and utilization. It really wasn't so much about outcomes. The outcomes was going to be how we subsetted the groups. But this is now about outcomes. So this is work that was originally supposed to be presented by Lonnie in Venice, Italy, before he passed. So I took his place. All right, so I'm going to go through the background, the research questions, the outcome and exposures, the data, I've already talked about data, the study design, statistical methods, results summary, and some implications. So this was originally for an international audience. So you all know that there's basically three ways that people pay for care. There's a lot of, especially mental health, a lot of consumers pay out of their pocket. A big section of folks, most of us, will have private insurance. Some of it's subsidized, some of it's not. And it's largely administered through private, for-profit, and non-profit corporations. And then there's the public insurance side. And that's primarily two parts. So it's insurance. Remember when this came out in '65, they wanted to cover everybody, but they couldn't get agreement. So they said, okay, we can get everyone to say, yeah, grandma should be covered. And we probably can get people to say, yeah, people who are lower socioeconomic should be covered, but we're not going to cover the middle. So we have the Medicare for the elderly and disabled. And then we have the Medicaid, who is largely for lower SES people, and then a number of people who have other kinds of conditions. So the impetus of this was the Affordable Care Act. And there were, this was all written by Genevieve for an international audience. So a number of states were incentivized to be Medicaid expansion states, where they would cover you if you're about 138% of poverty. And for some strange reason, that is it's the same across all the US instead of being adjusted for cost of living and purchasing power, and it is what it is. And adults that were eligible for insurance under Medicaid expansion are going to be disproportionately Black, Hispanic, and living in rural areas. And again, as we saw in the previous presentation, Medicaid is the largest funder of mental health coverage in the US. And during COVID, economists had nothing to do or less to do. So they sat around and all the big brain econometrician types made up all kinds of new things around difference and difference equations. So the field has completely changed. And so most of the previous work has been done using traditional difference and difference design. And what I mean by difference is we have the first difference is across time. So we have the pre and the post. And the other difference is across groups. So we have a treatment and control, right? So what they found is that in the traditional approach, it wasn't robust to different kinds of outcomes, different kinds of effects among people. A lot of heterogeneity was involved. So a whole bunch of folks decided we're going to work on this and see if we can solve this problem. They made a lot of progress. And a lot of the estimators now are available in R and Stata and packages that are fairly easy to access. Things are still going forward on this area, but a lot of it's been done. So we're going to look at estimators that are computations called consistent. And this is going to be the average treatment on the treated. So this is folks who actually got the treatment. And not treated as controls. But we're going to have heterogeneous treatment is going to be accounted for, and then staggered treatment is going to be accounted for. So the way it worked out with the ACA is that there's a lot of really states that cared more about people who put it in right at 2014 when everything else came in. And a lot of other states kind of slowly got brought in, and some states never came in. So there's three assumptions that you have to make when you're doing difference and differences. One is prior to the intervention, groups have to be the same. Not to be exactly the same, but they have to be parallel, right? Another one is that the policy has to be exogenous. It can't be something that you chose. And then finally, the last assumption is that you can't have leakage over from the treatment group to the control group. So, and that's pretty straightforward here. You don't have Medicaid, you don't have Medicaid. Can't get the treatment. All right, so this is our hypotheses. So we have low-income adults with mental health needs. And then some folks are going to live in a Medicaid expansion state. Some folks won't. The folks who live in the Medicaid expansion state will have insurance to cover lots of different kinds of mental health care. These folks won't. They'll have adequate access. They'll have limited care, and then hopefully we'll get some better health outcomes, mental health outcomes for this folks and this folks. Now, we're not measuring this part at all in this study. We don't have any data on whether they actually received care. So all we know is, did they get better or not? All right, so the behavioral risk factor surveillance survey doesn't have validated questions on mental health, but they're questions that the people who are being surveyed will understand. So one of them is, did you have, how was your mental health? Is it good? Is it not good? And then we looked at how that varied by subgroup. I'm not going to go into that. So the questions were, including stress, depression, and problems with emotions, how many days during the past 30 days was your mental health not good? So you have a sense of that. It may not be exact in terms of the intensity, but get something on it. And the next question was, during the past 30 days, about how many days did poor physical or mental health keep you from doing your usual activities? So taking care of yourself and things like that. So that's kind of an indirect way of getting at intensity. So we looked at, and it's a continuous scale, 0 to 30 days. So we had 3 outcomes. So did you have any not good mental health days? So we want to see just absolutely, was there any change at all? And then how many not good mental health was there given that there was any not good mental health days? And we would exclude from this people who had any kind of issue with their physical health, at least as they saw it. So we're trying to get a clean understanding of the mental health part of it. So if we get a reduction in the prevalence, that suggests that there's pretty significant improvements at the population level. So there's a significant elimination of just problems at least people are perceiving that they have. And then a reduction in intensity given prevalence, that's kind of more of a moderate improvement. So you still have the problem, but you just don't have as many days where you're having the problem. So it's still some improvement. All right, so most states did expand in 2014. big list there. 3 states expanded in 2015, and 2 more states expanded in 2016. 1 state in 17, 2 more in 19, and 2 more in 20. And since then, there actually have been a few more that have joined. So in terms of our covariates, we don't have a lot of covariates in this data set, but we have age. So we took the epidemiological approach and segmented it by group. We have sex, we have race, ethnicity, we have a lot of variations. We're going to focus on just 3 of these populations here. We have education. We had income constrained to less than or 138% of poverty, thanks to Alison's great algorithm that she gave me to figure this out with the Burfus. And we, again, we don't have anything on the causal pathway between Medicaid expansions and outcomes. All we know is that we assume there was some kind of change. But the real meat of this that we'd like to get into later is why these things are happening, right? Because we want to fix the problem, we just don't want to describe the problem. So we have this from 2011 to 2022. So these are all publicly available data. We have state level identifiers on here. Back in the old days, when I was a student, we actually had county identifiers on there, but some people decided they didn't like that, so I stripped those away. And there was a design change that occurred in 2011, so we didn't use anything before that. All right, so we used one of the early versions of the advanced difference models, Callaway, Brantley, and Santana. The comparison group was folks that were never exposed to changes in Medicaid, so the adults they never got anything. We took care of the complex survey design to make sure that we're making proper inference at the population level. We looked at parallel trends via event studies. You'll see lots and lots of graphs, lots and lots of figures after this. And we used a 2-part model. So we had a linear probability model, just an OLS with a dummy variable on the end to predict whether you were in or not. And it's okay if you have between 0.2 and 0.8 as your dependent variable. And then also with linear models for intensity given prevalence. All right, so here's prevalence for not a good day. So these are what's called dynamic event studies. So the average treatment on the treated effects are estimated for each period relative to the period that was first treated across all cohorts. So some cohorts started later, some started earlier. This accounts for all of that stuff in a single presentation. So this is all adults. So the parallel trends part is this. As long as these are differences across the treatment and control. It looks okay. And then after treatment, we don't really see much on the front end, but then we see this big drop. So there is pretty big effects in terms of having any poor mental health days. But then we're going to split it up by race, ethnicity. Well, this is white adults. So you start to see, this is the biggest group, so we should have the tightest confidence intervals, but we don't. So we're starting to come down here, but you don't get anything down here, and then it comes back up again. So you're not seeing what you necessarily would expect. To our Hispanic adults, this seems to be primarily driving the result. Pretty significant decline in any poor mental health days. And these are Black adults. So what really disturbed me was, even though these are big confidence intervals, we're going above the line here. We drop a little bit, but then it's still above. Yeah. All right, so then we're going to now shift over. So that was the big effect. This is more moderate effects. So maybe you still have any poor mental health days, but maybe you have fewer of them, right? So this is all adults. See a lot of nothing, but not for no. Sorry, this is number of poor mental days given any poor all adults. This is if anything, interfere with your activities. So you may have the same number of days, but actually it's not so bad each day. All right, so we are seeing some effects there. This is pretty similar to what you saw in the major graph. Comes in about 3 years into the process. So white adults, not much. Pretty big drop there, not statistically significant. White adults are getting pretty much similar to Hispanic in terms of the intensity given you have it. And then Hispanics, nothing there, nothing there. Black adults are not having fewer days, but they have a lot less intensity each day, almost immediately. But then for some reason, it kind of goes up a little bit in the middle there. So obviously, these would beg for explanation. Why are these patterns so different? And part of the R01 was to intensively look at why they're different in terms of the community characteristics and various things that are going on. Lonnie and Alison and Genevieve put together a very, very comprehensive analytic plan to look at this. We will be able to look at it. Our next step is to look at coverage and see how that might have had an issue across states. All right, so the overall finding was that there's really heterogeneous effects in the effects of the expansion. So there was a strong reduction overall, but when you unpack it, there's huge disparities. Hispanic adults benefited the most. White adults benefited also later in time. In terms of prevalence, no measurable effect for Black adults. In terms of the intensity given prevalence, with nothing overall. In terms of race ethnicity, we did have similar effects for white and Black adults. So overall, we'd say that actually Hispanic adults benefited the most out of this. Then there was, and white adults, and then, which we didn't want to see, and I'm sure Lonnie really would have been, he saw this before he passed, benefited the least. Right. So the implications here is there's a really significant issue for Black patients not showing nearly as much measurable benefit. I'm not entirely convinced that this is just a sample size issue, because this is a huge data set. But there's probably tremendous heterogeneity across states that what the heterogeneity is in each state that we need to unpack. So if we're going to have any policy to fix this, pretty important that we figure out why it's happening. So telemedicine is, Dr. Xiao pointed out, might be one way to get at this, and we don't know how that's across states, but there's a lot of issues. All right, questions? We have 5 minutes before we have the end of our.
All right, questions?
Thank you. I'm always good at pinning a lot of questions, throwing rocks. One of the questions actually I wanted to ask is that for the two outcomes, have you ever considered about combining them? It's I see that they are kind of related, but they're different, but then could be the intensity could be interact with the average days. And then people who consider the intensity part might also have a smaller group that on average they feel good or bad. Teasing that part out, I feel it would be very interesting because from some of the research I did with suicide preventions and disparities, I find that stress have different interpretations. And then for the intensities of the stress discriminations that maybe Black adults might interact with. They might feel good on average days, but not good for the intensities. And also, this is an annual survey. It's not like what we heard from other data, Medicaid or other real world data. It's like you need it and then you get it and then you seek help. But the survey could have like bias, but can be the nuance might be captured by creating a new variable that interact with the average plus the intensity part.
All right, that's a really good idea. It's pretty straightforward to do. I mean, I could do it tonight. Yeah, the number of days you had not good mental health, and then what was we could figure out some way to quantify how and do that. It's a great idea. Thank you. That might actually make it look a lot different. It might not. It may make it have us more questions, but we still need to look at it. So that's a great idea. Thank you. This is just Medicaid expansion.
I just had one comment I wanted to make. I just wanted to thank everyone for just really giving our family just a real insight into Lonnie as a professional, because we knew him as family. And I'm humbled by just the love that everyone has shown for him, but also his kindness, his compassion, his diligence. It really showed us, the real side of him that we really didn't know. And I just wanted to thank everyone.
Maybe what I'm going to do, so some of you may be attending, there's a School of Public Health event that reflects the traditional campus memorial at 5 at Berkeley Way West. And so we have a little bit of time before some people might want to walk or drive over there. But I just met with all the speakers really quickly. And I wanted to also thank Alice for working with me to try to think about how do we do this. And we had this pie in the sky idea, like, why don't we're going to have the speakers presenting Lonnie's most cutting edge work. So that we could see it in real time. And then much like Lonnie always does, like you think you're going in with an agenda about how you're going to likely summarize it. And so I was like, I've looked at all the titles, I looked up some of your work, and I was like, I know what my themes are going to be. And then of course they're not, they're kind of on the same theme, but it's much like Lonnie, you're left with new questions or new ways of thinking about that. So what I thought I'd do is invite the panel up for some concluding comments after I huddled with them about what I think and to just try to sum up what we did today. Maybe anticipate where you were going, the future a little bit, but then try to pull together some of the themes across these talks as they represented Lonnie's work. And we will try to do that. And audience members are invited to add themes. First of all, that was just so fun to just see all the presentations today and all the fractals of Lonnie's work, really. And so when I think about bringing this together, this was entitled Reaching the Underserved based on Lonnie's book. And, that is this enduring theme, although you have revealed to me that who we think as underserved can often shift, as represented in actually eating disorders, aren't just a white women's disorder or white upper middle class girl disorder. I was also just bamboozled. We say that Lonnie was methodologically pluralistic, but then what was gorgeous about this group was not, it's the novel use of data sources and exploiting them to get to policy relevant questions and hammering data to and being frustrated with it to reveal itself. And it's really, as Genevieve, you said to me, it's really because these are how you extract these bigger policy drivers potentially to make impact.
And how you find marginal populations.
Thank you. And then I think you all brought up again, I always think of Lonnie as a services researcher, but today I was reminded he's an area researcher too. He's both. He has, but many of you also talked about the ways we define areas. And I'm thinking about you, Dr. Xiao, and you, Genevieve, and like states are interesting how, when you really look and dig into the literature on area variation on these things, it can be more simple than we think, or there's room to illuminate those factors to again exploit within state, between county, within county, et cetera, within person, within subgroup data together to try to illuminate opportunities to better understand access and care issues. And then the final theme that I heard from you all was, what is a system of care and what is a system of public care responsible to? And I think you nuance that as well. So what is public care? And do we think of public care more complicatedly? And what is the role of the other parts of this net, knowing that we have three funders, private insurers, public insurers as well, and maybe thinking about this a little bit more collectively. So those were my summative points. Would it put the panel under a lot of pressure to correct any of the points I've made, or to add subtlety to what I said?
We could just go down the line. Yeah. I don't know. I think you said it all very well. I think for me, when I think about Lonnie and when I've met people that have been trained by Lonnie, and then there's this, people say things like, oh, you have the same lens as I do because we were trained by Lonnie and Lonnie has a lens. And my lens, my view of his lens is that it's very about structural drivers, including policy, including social determinants, including not necessarily things that are codified in policy, but structural drivers. So that's what I think had a lot to do with Lonnie's work. And I think that he, as a researcher, was someone who persevered, because I think doing this work, looking at policy and structural drivers and racial and ethnic disparities, were both and continue to be difficult to do, because people don't want to believe what your findings say. And I feel like what I learned from him is that you can take the feedback and you just keep going and you keep doing the work. And I just think that's important to say.
I think that's actually critical. So I never said, but I first met Lonnie when I was working at a research center before I was a professor. And we brought Lonnie in because my mentor at the time said, he's done everything in this area. And so I got his CV and I said, wow, he has done everything in this area. But just the constant keep putting out the paper, keep putting out the paper, look at this variation, that variation, this variation. In other words, you remove all attempts to criticize that it's really there if you have every single slice of it. And he's just done a tremendous job on that.
I think I want to summarize the themes that I learned a lot from Lonnie in terms of one sentence and three area. One is that the main thing I learned is like there's no boundaries of like exploring like the same things, and also digging into the question about mental health disparities and If there is no one doing it, then you should be the one. If there's no area, then you could create that area. If there are no intersections between mental health service use and informatics and machine learning, then you create ones. And if that, and the more people who learn, and then the more that one is important. And that really reflects to, first of all, there is like existence of mental health disparities. So we need to create more evidence, no matter what kind of data set, method that we use, we need to continue in creating the evidence that. Second, I think we need to continuing and understanding the mechanisms for that. And then as we all see from this afternoon, I see a lot of like different ways that we can address that. And finally, I think advocacies for policies is possible. And then I think that needs to really have a lot of like work from different people. And then I think the next step for me is to start collaborating with everyone here.
Well said. Yeah, I think what I learned from Lonnie was that the problems are very complex, and there are so many hidden pieces to the problem, but you can still get at that problem. You don't need to be intimidated by it, and you can create an elegant, simple solution to look at every single piece of that problem, as Tim said, one puzzle piece at a time to build that puzzle.
Yes, I agree with the comments, and I agree with your observations that we have a complex system of different insurance, and then we have mild and moderate and severe forms of mental illness. And then we all, to your point about eating disorders, have different systems that have to work with one another, the medical, the mental health, the criminal justice, the child welfare, and this range of social services. And he was able to look at studies across these complexities. And I think that was a special gift.
From a content perspective, Lonnie taught me a lot about different systems of care and how they interact. But I think the part of Lonnie that really touched me the most was the way that he did his work with such incredible integrity, such incredible passion, and his sense of curiosity was endless. And I loved that about him. And he brought his full self to all of the interactions that we had. I really felt that I knew him as a person rather than just an academic relationship. And I think the takeaways that I have from that in terms of his perseverance and being creative and is that you can do that while also having fun and being a full human and really connected. So that's something that I really appreciated about Lonnie and that I think is really unique for someone who reached his level of achievement and something that was really specific and special to him.
In many ways, this was most current research, and I hope you'll indulge me to because I want to go future here beyond collaboration. I mean, I think among this group, you are actually a quite tight-knit and coherent group together, but this represented near done or mostly done current papers, right? Right. But then there's a going forward. There's a going forward. And so maybe we'll just go down the line again. Where are you going in the near future?
Well, we're going to finish Lonnie's grant that he worked really, really hard to get. I will say that this project, we wrote 4 different versions of this project before it was funded. And so it's very important to me that we answer the questions that were set out in this project. So that's my primary Lonnie related goal. But we have had conversations already in the last 24 hours about the things that we want to do to carry forward other things that Lonnie cared about, including really using the opportunities that we have in the policies that were enacted during the COVID era to understand what can be done to close racial disparities in a wide range of outcomes. He has a whole paper about exactly what needs to be done, and I think we'll just try to do that.
That's a great point. One of the things that we were working on as Dr. Xiao has a grant that Lonnie was also part of. And one of the questions was looking at SNAP.
Yeah.
And before Lonnie passed, he was actually writing on SNAP. And I have the work that he did. It's about a quarter done. He was barreling along, and but there we have some even fancier than this econometrics that we can use to get at the question to answer whether or not COVID closed the gaps, because it's super important. If we can show that the gaps did get closed during COVID, then they can be closed at any time.
If we want to close.
Right, if we want to. So it's more of a question of will.
Yes, well, I have two work. Actually, one of my R1, Lonnie, is the co-investigators, and he has contributed tons related to COVID-related policies. And Tim and I was also working on creating fancier ways of but also concrete ways to addressing the changes. I know that this is a passion of him to really understand post-pandemic changes, whether those are effective in closing the gap. The second things I want to share that I think is a miracle. I shared it yesterday, but some of you are not here. But I want to share again that one of the grants that we submitted in February, which was the grant Lonnie and I was working on in January, just 2 days before he passed away. And I was 2 days before I came here, I was contacted by a program officer from NIMH. And then they said, oh, we regularly review some grants that submitted this year, and we are very interested in knowing if you are planning to submit this grant. And that is the grant that Lonnie and I was working on. And we got scored for the first submissions, and I was not sure which way to go. And then after I met the program officer, she told me exactly how to revise, what the NIMH wanted me to do. And I think that's Lonnie really telling me that just keep going in it, girl.
I think there's a lot of data out there that we're still not using to the capacity or that we could be using. There's a lot of Medicaid data, there's a lot of CMS data. And, I'd like to see, we do a lot of retrospective studies, but I'd like to see us do some predictive studies looking forward into the future and doing some testing of what impact treatment would have in a predictive way. So doing longitudinal predictive studies using neural networks with a lot of the data that we already have, predicting forward what treatment interventions would work, what access to care would do, and then predicting that savings and changing policies with future data.
And I tend to be focused on the care delivery system. So some of my work is in Medicaid payment. So the commercial payment versus the Medicaid payment and the kinds of gaps in treatment that those create. So that's a direction I'm going in currently, in addition to continuing in the space of mental health and criminal justice or juvenile justice.
I think we're just at the beginning of this line of research. So I think there's still a lot of questions that are unanswered that I'm excited to pursue in terms of where people are accessing care, how far they have to travel for that, geographic differences in terms of service utilization. And I'm really excited about the potential policy implications for some of this work and thinking about how to build a system that can both improve care and also reduce costs to be more efficient with our federal money. So yeah, I'm looking forward to continuing to do that work with Kate and in Lonnie's honor.
Thank you, Erin. Any final comments from, oh, Alice, I would love, thank you.
Oh, right here. Okay. So I wanted to take a moment on behalf of our family, of the Hines Snowden family, who were here yesterday and today, to thank you, all of you, so much for being here and for presenting Lonnie's work, which is your work. And not only did you present his work and his legacy, but also him as a person. So thank you so much for that. It means a lot to us to see his work come alive like you made it, and also to hear about the future and how his legacy will continue. And I especially want to thank Dean Stone and the School of Social Welfare for making this happen. I think it's wonderful, and people can listen to it again and again, and I hope that students in the future will have a chance to hear some of your words. But thank you from the bottom of our hearts. Thank you.